Okay.
We are live.
Yes. Praveen, let Chinmay share his screen, please.
Yes, he can now.
Please go.
Pramod?
Yeah.
Yeah, go ahead.
No, you go ahead, Pritam.
Okay. Good evening, everybody. Yeah. Welcome all to the AMSI Season 2, Series 4. So we, as usual, we start with the pre-lecture Mentimeter code. For the Menti code for the day is 56482. 56482. So all of you who are logged in, kindly mute your audio and stop your video. Please mute your audio and stop your video. Kindly log into www.menti.com or open your Mentimeter app and type the code 56482. So the code for Mentimeter app for today is 56482. We'll be starting the pre-lecture Menti questions in another 5 minutes. So kindly open your Menti app or visit www.menti.com and use the code 56482. Kindly log into www.menti.com and use the code 56482. Either open the Menti app or you can visit www.menti.com and type the code 56482. All participants requesting to kindly mute your audio and stop your video. Kindly mute your audio and stop your video. Kindly visit www.menti.com or open the Menti app and use the code 56482. We would be starting the pre-lecture Menti questions now in another 3 minutes. Your 3 minutes more. Kindly open the Mentimeter app or visit www.menti.com. Type the code 56482. All the participants who have just joined, kindly visit www.menti.com or open your Mentimeter app. Use the code 56482. We'll be starting with the pre-lecture questions. All the participants, kindly mute your audio and stop your video. All the participants who have just joined, kindly open your Menti app or visit www.menti.com. Use the code 56482 for the pre-lecture questions. We'll be starting the Menti app in a minute's time. So open your Menti app or visit www.menti.com and use the code 56482. All participants, kindly mute your audio and stop your video. Please open your Menti app or visit www.menti.com and use the code 56482. Chinmay, you ready?
Ready, sir.
Ravi, you ready?
Yeah, I'm ready. Should I switch on the video?
Yes,
No.
switch on your video and audio, please. So we wait for less than a minute now before we start. All participants, kindly open your Menti app or visit www.menti.com and use the code 56482. Chinmay?
We are starting.
Okay, thank you, Chinmay. Ravi, you can take over.
Yeah. So the first question for today is, the zygomatic implant is successful because it engages 4 cortical plates in the maxilla. And these are, the first option is alveolar crest, nasal floor, pterygoid plate, and tuberosity. The second option is palatal alveolar crest, sinus floor, inner and outer cortex of zygoma. The third option is buccal alveolar crest, pyriform fossa, infraorbital rim, and zygoma. And the fourth one is alveolar crest, pyriform fossa, infraorbital rim, and pterygoid plate. You need to click on the right option, which you feel is right. And you have another 50 seconds with you. Okay, I hope everybody has clicked the right option. Another 20 seconds. Okay, last 4 seconds, do it now. Okay, so the right option is second, and 43 of you have got the right answer. Next slide, please. So just a small discussion about this. The dense alveolar bone and zygomatic bone gives good primary stability and good osseointegration, along with absence of any peri-implantitis in this region. You can see that region with the red circles on both the sides. So these are the ones which results in a good biological barrier. And this biological barrier prevents any ingression of bacteria, which is the cause for your crestal bone loss. Okay, so next question, everybody ready? Next slide, please. Okay, now, which of the following statements are true to original Brennemark zygomatic implants? Mind you, original Brennemark zygomatic implants. Okay, the first option is a tapered cutting tip. Second is a machine surface. Third, it has a roughened surface. And fourth option is it is an internal hex connection. So please answer now. Tick on the right, which you feel is the right statement for original Brennemark zygomatic implant. Please do not answer in the chat. Okay, the right answer is second option, which is a machine surface. In detail, it will be discussed in the lecture. And the first one is an original Brennemark zygomatic fixture. And the machine surface is basically, it's an anisotropic. That means it has a clear orientation of surface roughness, which results in increased surface area, eventually giving more BIC, the bone implant contact, and leading to a higher success of your implant. Okay. So the next slide, please. Okay, which one of the contraindications for placement of zygomatic implant? The first option is diabetes, second is smoking, third is rhinosinusitis, and fourth one is the bleeding disorders. Absolute contraindication for placement of zygomatic implant. Just click on the okay, the right answer has the maximum ticks. So the right answer is rhinosinusitis. Okay. The reason the first picture what you see is the endoscopic view of the intrasinal part of your zygomatic implant, which is devoid of bone. If you can see my pointer over here, it's devoid of bone. You can see the inflamed Schneiderian membrane here. Okay. And you can see some debris around it. This is confirmed in the CBCT on the adjacent picture. If you see on the left side of the patient, you can see the inflamed Schneiderian membrane. Okay, so and along with that, the nasal lining. So everything is inflamed, showing it as a gray area. This is the normal side. The right side is the normal side. Very thin Schneiderian membrane over here. So it's a good idea to have a CBCT as your treatment planning, so that you can rule out all the rhinosinusitis cases and prevent any failure of your implants. Next slide, please. Okay, the zygomatic bone is usually, sorry, this is it's written compromised. It's supposed to be comprised of which type of bone? So there is a misspelling there. So which type of bone? It's D1, D2, D3, or D4? D1 is purely cortical, D2 is majorly cortical and less cancellous, 3 is equally cortical and cancellous, and D4 is a soft bone with sparse trabeculae. So the right answer is, okay, only 25 of you have given the right answer. The right answer is D1. The picture shows the classification of your D1, D2, D3, D4. So the first picture shows a very minimal amount of any cancellous bone. It's mainly the cortical bone, and the zygomatic bone is almost purely cortical bone, the D1 bone. The D2 is a mix of cancellous and majorly cortical bone. D3 is almost equal amount of cortical and cancellous bone. And D4, difference between D3 and D4 is the cancellous bone has very sparse, the large trabeculae in the cancellous region. So that's different. So it's mainly the D1 bone in the zygomatic bone. bone. Next slide, please. Next slide, please. Am I audible?
Yeah. Chinmay, is there a problem with the app? It's not moving.
Yeah.
Chinmay, come in. Praveen, is there a
Okay.
problem with Chinmay's
His
internet?
message is net is down. He's
Yeah.
reconnecting.
Net is down.
Okay, okay. Just wait. Let's wait for a couple of minutes, please.
Yeah, yeah. So meanwhile, we can just discuss that your primary stability of the implant is mainly due to the cortical bone. So therefore, the primary stability in the zygomatic implant placement is really high. Whereas your cancellous bone is equally important, but that's for the biological osseointegration. That plays major part in your biological osseointegration because it has abundant blood supply. But your primary stability
Chinmay
while
is back.
placing the implant. Okay, next slide, please.
Chinmay, Praveen, let Chinmay share the screen again.
He has tried to log in. He'll be
He's-
logging in now.
Okay, fine. Yeah. Okay, we'll wait for a couple of minutes. Ravi, you can summarize till then what you were doing.
Okay, I don't have that slide with me, but I mean, that's what I was saying. So you have all D1, D2, D3, and D4 types of bone. The D1, as we said earlier, it has majorly the cortical bone, which helps in your primary stability when you're placing the implant. So zygomatic, the first question which said zygomatic implant placement takes multiple cortex engagement. So that is why it has a very, very high primary stability. Cancellous bone is equally important for your secondary stability. That's your biological osseointegration because it has abundant bone building cells, bone forming cells, the osteoblast. So that is why it is important in your secondary phase. Anything you want to add?
Praveen, is it sorted? Chinmay is back?
That too, sir. He's connecting.
Okay. Ravi, how many questions we are done with?
We're done with 4 now, and we're coming up with 5th. Another 2 left.
Okay, all right. Okay. Hello.
Hello.
Ravi, thank you. Chinmay's net is crashed for some reason.
Okay.
So we'll do those 2 questions at the post lecture.
Sure.
And we'll carry on with the rest of things. Amit,
Yeah, I'm here.
Amit, come
I'm
in,
here,
take
Preetham.
over.
Yeah. Thank you, Preetham.
Yeah.
Thank you, everyone. So I'm here to introduce the co-hosts. So first of all, we have YouTube co-hosts. We have Dr. Sankalp Mittal, who enlightened you yesterday. Sankalp, you want to say hello?
Hi, everyone.
Yeah. Then we have Dr. Ravi Batra, who just had this Mentimeter thing. Dr. Ravi.
Yeah, hi everybody.
So now we have three Zoom co-hosts today. Dr. Nitin Ahuja from Delhi. Nitin, you want to just say hi?
Yeah. Hi everyone. From
We
Mumbai,
have-
but
Yeah, from Mumbai. I'm sorry. So Dr. Mukul Padhye from Mumbai. Everyone knows him. Mukul sir, you want to say hi?
Hi. Hello, everyone.
And we have a prosthodontist on board today, Dr. Ashwini Awar from Chennai.
Hello everyone.
Hello, everyone.
Thank-
Nice to be on.
Thank
web
you. Thank you.
series.
So now I would request our president of AOMSI, Dr. Veera Bahu, to introduce the speaker of the day. Over to you, Veera sir.
Good evening, dear colleagues. It's a proud privilege and honor for me to introduce my guru, mentor for everything, Dr. Gunasheelan, to you all. Actually, introducing Dr. Gunasheelan to the AOMSI is like introducing Spielberg to Hollywood. Everybody here knows him. So for the benefit of people who are seeing from other countries and the young colleagues, is one of the few dually qualified maxillofacial surgeons from India. He obtained his MBBS from Madras Medical College, the prestigious college, in the year 1985. And he obtained his BDS from the Annamalai University from the year 1988. He also went on to do FDS RCS and got his fellowships from UK, I think in the year 1990. But he returned back in 1991 to take care of his college opened by his illustrious father, Dr. B.P. Rajan, in the year 1991. From then on, he trained numerous students, and we were all trained by him. In the year 2005, he established a state-of-the-art multi-specialty dental hospital called Rajan Dental Hospital, where he teaches and trains students. His area of interest are orthognathic surgery, cleft lip and palate, and dental implants. Today, he is here to share his vast experience and knowledge about zygomatic implants. Remember, he's a world leader in implants, and he is also examiners for implantology in Royal College. Sir, the virtual floor is all yours now, and over to Dr. Gunasheelan. I felt like as if I'm still presenting the seminar to you in front of the college days. Over to you, sir.
So before you start, can we run the AMSI web series music, please?
Yeah.
I think there was a clash when Praveen was running it. Thank you, sir. Please.
Over to you, sir.
Hi, good evening, one and all. It's a fantastic feeling, but I only feel that, these are things which bring people like us out of the woods, We thought we finished everything in AOMSA and we're happily leading a retired life, and the webinars shake you and bring you back. And it's also very interesting because for the first time, I think we see all the office bearers sitting and listening to us, the presentation. Because invariably, in the conferences, all of them are busy with that meeting, executive meeting, and running around. So it's a real privilege for us to speak to a really enlightened audience. And from what I've heard from Preetham and others is that we get huge numbers listening and watching. So it's a good feel for your ego, I suppose. And it's a lovely feeling getting introduced by Dr. Veera Bahu again. One of my most illustrious compatriots. And I'm very happy that he's done himself proud in the AOMSI. So, shall we get started? Shall we go to the
So before you start, I just want to request all participants to keep your audio muted during the course of the session. Please keep your audio muted and your video turned off. Continue, sir.
Shall I? Okay. Okay, so let's get to the. Okay, is that clear? What?
That's clear, sir. That's
Okay.
clear. Yeah.
Okay.
Yes, sir. Proceed,
So,
sir.
great. Okay. So today I've been tasked with talking about Zygoma implants for full arch rehabilitation. So this is a great option for dentoalveolar rehabilitation when you have completely resorbed maxillae. So let's start with severe maxillary resorption. So we know the classical description by ECOM, where we have the A, B, C, D, E sort of resorption. When you come to this sort of E resorption, you're virtually left with zero bone. So look at this lady in the mid-40s with almost just 0.5 millimeter of bone in the entire maxilla, including the posterior maxilla. What would you do conventionally in a situation like this? Conventionally, you would have to do maxillary augmentation, both onlay plus maybe bilateral sinus lifts. If you're doing onlay for such a large area, you have to go get bone from the iliac region, and then you have to do the implant placement. And the implant placement is done in stages. You do the graft, you wait for about 6 months, and then only you go and do the fixtures. And then once you do the fixtures, you need to wait another 6 months for the fixtures to heal before you do the definitive prosthesis fabrication. So this is a long drawn process, almost a 1 year process, and during which time the patient may not be able to wear prosthesis, even a removable complete denture for long periods of time. Like after the bone grafting, you have to wait for the tissue to heal before you give the graft, etc. So this is a long drawn process. What is the alternative? The alternative concept, called the Zygoma concept, was given by none other than Professor Brennemark himself. I mean, this is one of the most remarkable scientists that I've come across. I've seen in the last few decades, from making some landmark observations in the lab about osseointegration, and then doing a clinical work on mandible, and then working with maxillectomy patients in Brazil and seeing how to rehabilitate them, and realizing that the zygoma bone, which is just adjacent to the maxilla, is a great option to rehabilitate. Because unlike the alveolar bone, which resorbs with age, this is going to remain the same throughout life, the dimension of the zygomatic bone. And you heard Dr. Ravi Bhatta talk about those 4 cortical contacts, which makes this an interesting option. So he actually first described this in 1998, but the first publication came out much later. So this is, I think, what alluded by Ravi about this 4 cortical contacts for this Brennemark implant. So although he did describe this in 1998 in a small publication, the real international exposure came only after he published this in the JPD in 2001. And mind you, even at that time, he already had a 5 to 10 year follow-up and had a phenomenal success of 97%. Following which, Chantal Malaby in Belgium published her outcome in 103 patients with a long follow-up. And again, look at the success rate of 100%. But what's interesting is then after that, it really took off, all over the world, in Malo, Aparicio, Balshi, different parts of the world, Mozzati, Ruggiero, and Bedrosian, Migliorani. So you see huge number of people starting to do this. And if we look at the column on the right, the success rate is, again, phenomenal. It's averaging, above 97, 96%, which is, except for people, implants done in maxillectomy patients in a conventional situation, they were all upward of 96%. So this was a great dentoalveolar rehabilitation option. what are the indications? Classical, of course, would be the severe maxillary atrophy, but increasingly people are beginning to do it even for moderate maxillary atrophy. And then certainly for patients who refuse bone grafting and patients who had failed sinus grafting procedures. So we know that sinus grafting procedures success rates are in the order of about 85 to 90%. And once you have a failure of the sinus graft, then you have very little options left. So these are some of the situations: full arch edentulosum at a fairly young age, terminal dentition. People do walk around with such teeth. And I'm sure most of you see these sort of patients even in your practices. Developmental and acquired defects in the maxilla, and also sometimes for partial edentulism. And see, these are segmental defects are also good options. Another great indication I've seen is GAP. So people were a little reluctant to do implants itself in GAP. And then we saw some small reports coming on localized 1 or 2 implants, and also a few reports on sinus lifts, but no reports on full arch and zygoma implants. And then we did a few patients and published later on using zygoma implant for GAP. And we know that GAP is again in a younger population. So it's a great boon for such patients if they can have a total clearance, implants immediately, and immediate provisional processes. Syndromic patients, ectodermal dysplasia, cleidocranial disosters, again, patients who can really benefit with this. So this is a papill only for a patient who had zygoma implants and provisional processes. We need to be cautious about certain conditions, of course. They are not real contraindication. That's why I say I use the word just be cautious. Any systemic conditions which are contraindications for implants will certainly be contraindications for zygoma implants. Any acute sinus disease, that's a contraindication. You need to be extra careful. You need to really talk to the patient, communicate well before you even think of doing an implant in a sinus disease. In acute sinus disease, chronic sinus disease is not a contraindication. The critical thing is restricted mouth opening. See, we don't think of this much, but then because of the armamentarium, you need to have very good mouth opening. You need at least about 45 millimeters opening interarch anteriorly if you're able to get your instrumentation right. So in our country, especially with submucous fibrosis and issues of restricted mouth opening being much more common, please make sure that you check the mouth opening range before you get into this treatment planning. If the opposing arch is natural teeth, that can also make it even more technically difficult, because getting those angled hand pieces into the position can be difficult. So it may look something innocuous, but you need to be careful about all this when you're planning for zygoma implants. Let's look at a little people that applied anatomy. One of the important things that's followed a lot is what's called the Zaga classification, the anatomical classification described by Aparicio. So he goes by the amount of the configuration of the anterior wall of the maxilla. And he classifies it type 0. Type 0 is when the bone is almost, the anterior wall of the maxilla is almost straight, and the implant head is in the crest. The body of the implant is completely within the sinus, and then it gets anchorage in the zygomatic body. It's fairly straightforward. But once you look at the type 1, where you have a slight concavity in the anterior wall of the maxilla, then if you have to have an ideal position for the processes, that head of the implant, and of course the apex being the zygoma, some of the implant threads start coming out of the maxillary bone. So you're not confined within the sinus anymore. So depending on how more concave this gets, type 2 and type 3, the implant gets more and more outside the sinus, until at a type 4 situation, the entire implant is outside the maxilla. So here you can understand, you do not get these cortical contact here and here. Normally, if the implant entered the sinus, intrasinus, you would get a cortical contact here at the crest and one more cortex as it enters the sinus. And then the other cortex, the 2 cortices here. So in a completely extrasinus approach, see the head of the implant is completely outside, body outside, and only the apex inside the sinus. So it's only basically two cortical contacts. So that's a Zaga 4. You need to know two more dimensions as far as the zygoma is concerned. What is the AP length? Because sometimes you may need to use more than one zygoma implant on each side. People have described 1, 2, even 3 zygoma implants on each side in some articles. So if you look at this AP length of the zygomatic bone, you see the range is between about 14 to 25 millimeters. So that's a fairly standard, and even if you have 14, you can usually will be able to get 2 implants if necessary. And then the other thing that you have to look for is this one, the mediolateral thickness of the zygomatic bone, and which is averaging between from 7.6 to about 9.5, which means if your implant is usually about 3.9 at the apex. So even if it was 3.94 millimeters, you would still have adequate bone on either side, even if it's at 7.6. So the mediolateral thickness is the range that you get, about 7.6 to 9.5. And then if you look at the entire zygomatic bone, the thickest bone, the strongest bone is somewhere here, okay, where you have the lateral orbital rim. So you need to look and focus to get your point of purchase somewhere here. This is a sort of what's called the point jugulaire. And here, the junction between the zygomatic temporal process of the zygomatic bone and the frontal process. This is another area we should try. This is a sort of area that should try to engage the zygomatic implant, where the zygomatic implant should emerge. After it goes into the sinus, traverses the zygomatic body and tries to emerge here in this sort of region. This is the best region that you can, the best bone contact that you'll get. What is a bone implant contact in these zygoma implants? So Balshi's article shows a mean bone implant contact of almost 15 millimeters, plus or minus 5. So this is pretty good bone contact. What is more interesting, the lowest contact is 4.9, which means just 5 millimeter of bone contact in the zygomatic bone is enough to give you the stability and the support for a full arch. So that's what's very interesting. Imagine this, with 5 millimeter contact in the zygomatic bone and a long implant, you're still able to restore the processes. The average is though around 10. So you see the range, but mean is about 15 millimeters of bone to implant contact. So to sum it up, these are the reasons why we use a zygomatic anchorage, because you've got a mean width which is pretty satisfactory. You've got a good bone implant contact. Although the bone is trabecular, it's got very strong cortex with osseous density of about 98% and multicortical anchorage. Let's go to the treatment planning per se. So this is an interesting article published by Bedrosian, where he describes these 3 zones: the anterior zone, zone 1, the premolar zone, zone 2 on either side, and then the molar zone, which is called zone 3. So he says, classify this and then look at the amount of bone available, the quantity of bone available in these 3 zones, zone 1, 2, 3. That will be giving you sort of a stepladder decision tree to see how you can plan what type of implant for the maxilla. For example, if you have bone in all the 3 zones, you would go for the traditional axial implants. So you would say 1, 2, 3, 4, 5, 6 implants, 6 to 8 implants you would do in the maxilla, traditional axial implants. If you have bone only in zone 1 and 2, and this sinus is getting a bit larger and expanding down, you would tilt this implant, posterior implant. You heard a good presentation by Sankalp yesterday on this. So you do an all-on-4. If you have bone only in zone 1, so you would put 2 or 4 anterior implants, conventional implants, and then do a zygoma implant on either side. And if you have no bone in any of the zones, then you would go for a quad zygoma, 2 zygoma implants on either side. So this is a simple anatomical sort of requirement for the planning for zygoma implants. Of course, as surgeons, we are very comfortable when you look and plan on bone. So this is a very simple sort of straightforward thing to plan. However, over the years, if there is one message that I'd like to give you, please don't go only by your bone-based anatomical planning. Why? In the long run, you'll see these come back and haunt you with problems and more problems. You need to plan based on restoration. So it is reverse engineering. You patients want a prosthesis which is looking nice, aesthetic. So you need to give them the aesthetic prosthesis which is functionally long-term. Okay. So you have to plan with the end in mind, the processes in mind. So which means straight away, so the next several slides, I would say, can be a bit challenging for people who are completely surgically oriented. But believe me, it's well worth either you bring in a team member to help you with the processes, or you have to learn these prosthetic parts and terms and understand the planning to have good long-term results. There's no shortcuts in this. So when you look at it from the restoration point of view, what is the first thing that you would think of, whether you can give a patient a fixed or a removable? Obviously, the patient wants a fixed one, right? So they will ask, but it's not in all patients that you can give a fixed. There are sometimes a fixed is detrimental. So you need to evaluate whether you can give the patient a fixed or a removable. A fixed will, of course, be very nice screw retained prosthesis. A removable will be something like this with a bar and an overdenture. So this is a very nice sort of comparison as far as patient-dependent factors are concerned. So the phonation is a little more difficult in a fixed compared to a removable. The gag reflex is, of course, fewer in a fixed compared to a removable. Hygiene maintenance is far easier in a removable. Economics, certainly less expensive in a removable overdenture. So keep this in mind. This is the first thing that you would run through your mind. What does a patient want? Obviously, the patient will want a fixed, right? But can you give a fixed? What is the patient's mindset? What is their hygiene capability? Look at all this and then decide whether you can offer it or whether you should give them an alternative option. That, oh no, for you, it's better to do a removable option. Another very important thing, look at the AP position, the skeletal AP position. All of us learn to do orthognathic. You look at them three-dimensionally. You look at the AP profile. Look at these patients also, AP profile. The AP position is going to be determined a lot by what I mean by AP is a skeletal position, the maxillomandibular relationship, and the amount of lip support that the patient would need. Now look at this situation for a patient who came to us with a failing upper bridge. But my concern is, can I jump in and do a zygoma? Look at this patient. It's a severe class 3 with almost a 15 millimeters reverse overjet. If I try doing anything fixed on the patient, you're asking for trouble. Okay, the problem is nothing to do with these implants. It's all to do with your planning. Look at the mandibular plane. You can imagine the forces that this will be creating. Look at this class 3 discrepancy. This patient, you have to advise them, please go for a removable overdenture option. If the patient is still insistent on a fixed one, then you would rather move the maxilla forward, get them into a favorable skeletal relationship to the mandible, and then do the zygoma implants as a second stage procedure. Although today I've seen reports of doing this simultaneously, a simultaneous Lefort-1 advancement with zygoma implants. But if you're going to start off, I think you should convince this patient, if you want a fixed, you have to go through one more procedure, which is a Lefort-1 advancement. Or else you should insist that they do a removable option over denture. Just to show you how interesting implantology can be. Right, then of course, if the patient is edentulous, you can do what's called a trial denture, a complete denture, which can help you see whether you need a lip support, the flange support. So here you can see how this patient has a very flat, unsupported, thin lip, and who will definitely need a good support flange. So once you need a flange, you obviously have to go for an overdenture. There's no question of a fixed option. So look at this interesting situation. See, if you need to produce more lip support with the tooth, you can, but then you'll have this sort of a severe angulation. A pink acrylic, which will have a 45-degree or more angulation, which will, every time the patient is going to talk, this lip is going to get trapped on top of it. And they'll have to sort of move the lip down, as a separate effort. Oral hygiene issues, and patients will start smiling lesser, which you don't want. So these are the issues as far as the planning is concerned. And see what happens. If you see a situation like this and the patient wants something fixed, all you have to do is trim this bone. Take off this bone from here to here. If you recall, this patient has very good bone, so you're very happy you can do some implants. But if you want to avoid this, then you need to go and do an ostectomy. You need to plan an ostectomy like this. So once you do an ostectomy, that angulation doesn't become so obtuse. So you got a much better angulation, a little more flat, and you got a pink support for the lip. Something like this. See, once you take off some bone, if the bone was here, if I've taken off the bone, you can see the gentle slope of the prosthesis. So reduction of bone height sometimes is needed for the prosthetic point of view. Largely, most of the bone reduction that I do is for the sake of prosthesis, to have a good long-term prosthesis. I remember I told you about the AP position. Now you have to look at the vertical position. As far as the vertical position is concerned, these are the three important things. So those of you who want to plan, please remember these three things. One is a smile line and transition zone, the lip support, and then the space for prosthetic components. Please remember this as one landmark slide for you for planning. For the vertical positioning, to know how much of bone ostectomy you need to do, these are the three important things: your transition zone, smile line, lip support, and space for prosthetic components. So what do I mean by this? This is a smile line. At rest, you can see some of the gingiva and probably a little bit of the bone, underlying bone is supporting that. So this patient obviously has a high smile line. So look at the bottom slide. So if the patient smiles, they're going to expose a lot of the gingiva. And the biggest problem is getting this, to match the natural gingiva color to your pink acrylic or pink ceramic is the biggest challenge. And this will be very noticeable the moment the patient smiles. So the transition zone should not be visible. So you should really have something like this where the transition zone is taken under the lip during smile. Again, something like our orthodontic procedures. You need to plan how much you want to do, like how you want to do the maxillary setup. You need to do here maxillary bone reduction in the anterior maxilla. So you need to plan this depending on the smile line and how much you want to hide the transition zone. So you don't want this, right? And then if you have a situation like this, then you have to go and do an ostectomy. So this is where the planning becomes important. For example, if this patient had enough bone in zone 1 that you thought, okay, you can do an all-on-4, by the time you do an ostectomy, the patient has lost a lot of bone in zone 2 and 3 that it becomes converted to a zygoma. So sometimes what you plan on a radiograph or on a CT scan based, see, this is another thing we get sent scans and all that and say, we look at the bone scan and say, oh, I can do a convention, I can do an all-on-4. If you're not seeing the patient's smile line, a transition zone, the vertical dimension, you will cut a very sorry figure at the end of the day. So please plan this preoperatively. And this is what you should try to aim and not like what you saw earlier. The third important thing for vertical space requirement is the space that you need for the prosthetic components. So those who are familiar with it, you'll know that you need your multi-unit abutments, and then the angulation of the multi-unit abutment will also determine what will be the collar length of those abutments, the polished collar length, etc. And one simple thing, clue for you is, look at this. If you want, let's start from below, because this is the commonest thing that we normally do, these two. Either an acrylic bonded titanium fixed restoration or implant supported overdenture, for which we need 15 or 16. Keep 16 millimeters as the absolute minimum that you need for one prosthetic components and the processes for the arch. So you need minimum 16 millimeter space for this. If you're doing, of course, zirconia or monolithic zirconia, you can do with less bone or less space. But if this is the conventional thing that we normally do, either a chrome cobalt based bar and acrylic or titanium based acrylic restoration or an overdenture, keep in mind you need 16 millimeter per arch. You need 16 millimeter space per arch. So if you're doing a bimaxillary procedure, you need to have about 32 millimeters of space from one arch to the other arch. So keep this in mind, because people get into problems if they don't keep the space requirement in mind. So now come to the clinical factors as far as the difference between a fixed and a removal are concerned. So we looked at it earlier. I'm just reinforcing it, that if you need lip support, you need to go for a removable. The lip length is long, you can do fixed. If it's short or thin, you need to go for removable. And the smile line between low and high. Then you would calculate the number of implants that we need to do. This is again depending on the forces. So we know the formula of stress is equal to force divided by area. And that's the reason you also have to look at the magnitude, direction, and duration of the force and multiplication factors. So how can you increase the area? You can increase the area by increasing the length of the implant, the width of the implant, and certainly the number of implants. So see a situation like this. If you have a denture or a prosthesis opposing the arch, 2 Zygoma implants and 2 anterior implants are enough, because you do not have too much of forces. If you have more forces, like if you think the patient is a bruxer, then you automatically need to have more implants. You will have 2 Zygoma plus 4 implants rather than just 2 implants. Plus, you need to look at supportive measures like giving them a night guard, or maybe using some Botox injection for the masseter. You need to get the bruxism under control. That's very important. Now, sometimes we do a partially edentulous situation, like a situation like the Zygoma and a few implants. If your opposing arch has got natural teeth, you need to have more implants. As simple as that. Then determining the implant position is much easier if you have a try-in. Then you can duplicate the denture in clear acrylic, and then incorporate radiographic markers and do one more radiograph or a CT scan imaging to know approximately in relation to the molar, how much bone do you have. So this gives you a much more accurate planning depending on the availability of bone in different regions of the processes. Otherwise, you'll never know where the first or second molar is going to be. And it will also help you determine where exactly your emergence of your prosthetic screw will be. You need to keep it within the arch. The next thing will be what's called the multi-unit abutment. So another mistake that people make is the depth of implant placement. The implant should be fairly deep enough, because the angled multi-unit abutment will have a polished collar which is quite long. And if this is coming out of your gingiva, this will be unaesthetic, this portion, because no way you can cover it with any ceramic or acrylic. So you need to bury this deeper, at least about 1.5 to 2 millimeters deeper in the bone. So please keep in mind that when you're using angled implants, and Zygoma is also one, you need to bury it a bit deeper. Very important to keep that in mind. And the same goes even for the anterior implants. If you keep it little superficial, then you'll have this collars exposed, and it can be quite nasty when the patient has a high smile line. So I've just, I thought I'll stop here, because we have come to the treatment planning part of it. And the planning, the applied anatomy, the planning with the end in mind, the processes in mind. So this is the first part of the presentation. Soon after this, we can start with the surgical protocol, surgical techniques. So we'll hold here for now to take some questions.
Yeah, Guna.
Yes, Mukul.
Can you hear me, Dr. Gunasheelan?
Yeah, very much. Yes, very clear.
Yeah. Yeah, nice presentation. A couple of questions which have come in and which I would like to ask you. One is, that means I think planning is just like all surgeries. Planning is extremely important in this. Do you involve your prosthodontist colleague right from the start when you do the planning, one? And secondly, do you make the prosthesis before you actually go in for the surgery, or it is done? And what do you do if that is the case? Then what do you do in people who are having teeth, maybe like a periodontitis case, where you're going to extract at the time of surgery?
So yeah, okay. So yes, our planning is always a team. We have a luxury of having a prosthodontist with us always. But if you don't have, you can always take the help of a prosthodontist. That's important. And increasingly, I'm also taking the help of my radiologist, because the planning is also so crucial as far as the radiology is concerned, the softwares that you have, and the wonders that you can do, especially with making surgical stents and digital planning, especially in relation to the emergence of the abutments and all that. So certainly, a prosthodontist will be there right from the beginning. If the patient is completely edentulous, certainly you should make a prosthesis, and then you duplicate it, and it helps in the planning. And also sometimes making a surgical stent. If the patient has got teeth, a lot of teeth, if the patient is willing to have it extracted beforehand, you can do the same thing, but a lot of them wouldn't want that. So in those situations, we cannot have a preoperative denture ready. Although people can still do it, you can, like how we used to do immediate complete dentures. We take a model impression and then we knock out the teeth and make a rim. At least you have a bite rim. And so you're ready to take the jaw relation when you finish the implant. That much you can do.
Okay. Then one more thing, you mentioned in your caution about if there is a full complement of teeth, it's difficult to instrument, right? Because of your instrumentation may not be. Is that a contraindication kind of? You cannot do it at all if there's a full natural dentition of teeth, or it becomes just a partial?
It becomes a bit more difficult actually. So it's not an absolute that's why we use caution. So basically, if that's your first Zygoma patient, please don't do it. If you have a full complement of natural teeth in the lower jaw, to stretch the jaw and to get the instruments past the lower molar teeth, either you'll be chipping off some of those teeth lower down, all right?
Okay.
So you don't want to do it. So once you get a little more experience, you can overcome all that. But that it's a technical difficulty, especially because we have only angled long shank burrs and long handpieces. So that's a bit of a challenge. It's a technical challenge.
Okay. Another thing is one more question which has been asked on this is if when in axial implants or normal implants, when 5 millimeters bone is less, how is it possible that when you have got only anchorage of 5 millimeters, you talked about the bone implant interface, that is enough for holding a Zygoma implant, which is so big and long?
Yep. So Zygoma implants actually defies logic sometimes. It defies a lot of logic. One, remote anchorage. Your anchorage is in the tip and the entire implant is not unsupported. It still works. Okay. It works even when it becomes an extra sinus implant with no bone on the side. It works when it's angled. People, when we started implantology, everybody was saying axial loading, straight implants, you can't tilt the implant. Everything has become tilted today. So we are seeing a complete shift of what we knew earlier and what it is now. And there's enough finite element analysis studies to show that this works. And of course, enough papers and clinical outcomes, and you've seen the success rates. So that's not an issue. That 5 millimeter contact is as good as a 10 millimeter or 15 millimeter contact. But obviously, you need at least 5 millimeter. You can't be less than that in the Zygoma.
Okay. One question can I ask Dr. Ashwini? Your prosthodontist is also on our Zoom chat, right?
Yeah.
Dr. Ashwini, are you there?
Yes, I'm available.
Yeah. One of the questions which was asked is, can a removable overdenture prosthesis be given on a Zygoma implant?
Yes, absolutely. A removable overdenture prosthesis can be given in a Zygoma implant. Is my audio clear?
No, there is some echoing.
Is there any other device next to you?
Yes.
You have to turn off any one of them, otherwise it will get echo.
Hello, can
Can
you
I
hear?
ask? Yeah,
I
we
think you've
can
got
hear.
a
Yes, ma'am.
growing a beetle nearby.
Yeah.
Hello, can you hear me?
Now it
Yeah,
is
now it
better.
is
Yeah.
better. Yes, ma'am.
Yeah. So we can give an removal overdenture prosthesis on a zygomatic implant, and sometimes it is the most advocated prosthesis in patients who have a very less lip support, or in the patients who have a very short and thin lip length. And in cases when a overdentured zygomatic implant supported prosthesis is given, even there'll be fewer phonation problems, oral hygiene becomes very much easier. So yes, of course, zygomatic implants can be supported with an overdenture prosthesis.
Oh, thank you, ma'am. Nitin, you would like to
Yeah,
ask?
yeah, there are, am I audible?
Yep.
Yes.
Yeah, so there are two questions on the Zoom chat. So the first question is, if lower full dentition is present, so is zygoma is contraindicated? If not, then what are special considerations to be kept in mind if you have lower full arch of natural dentition?
Right. If
Yeah.
if you've got little experience, certainly you can do the Zygoma implant. But if it's like I said, if first or second case, don't do it. Look at alternatives. You go be a conventional. Whatever you would do conventionally, you would do a bilateral sinus lift, wait for 6 months, place implants in the posterior zone, and then do a conventional process. Option two, you could try a pterygoid implants. That's also an option.
Okay. So now the second question is on pterygoid. Why not pterygoid implants over zygomatic implants?
What are the
Okay.
advantages?
Okay. Okay. This is one of the things I commonly get asked. I've done a few pterygoid implants, three to be precise, four to be precise. Why I don't do it as a routine? For me, it's a blind procedure. When I can, if there's a choice between a procedure where I can see where my implant is going versus a blind procedure, I would prefer something what I can see, which is what is in the zygoma. I can see what I'm doing. Especially with the extra sinus technique that you'll see later, it becomes a little simpler and a little safer. So for me, it's a much safer and a thing that's under my vision, my control. A pterygoid, then second thing for me, I would look at the literature, what is happening to zygoma implants versus pterygoid implants. Zygoma implants literature increasing day by day, more and more publications in peer-reviewed journals, more and more proper, good studies, good levels of evidence. If you look at the pterygoid implants, there is good literature, but most of the studies are retrospective. So you know the level of evidence is not great. And if you look at one systematic review that came out, I think in late 2018, they had out of about 3,000 implants, almost 2,500 were done by just two surgeons. One is Dr. Balshi, and I think other one is Rodriguez. Between the two of them, they've done about 80% of the implants data that was published. So for me, pterygoid implant can be a little operator sensitive. See, some people can do wonders with bone and with anything, right? And others can't. So I think pterygoid implants are little technique sensitive. So if you are gifted, you can get fabulous results. If you're not gifted, you may not get. And these two surgeons had the largest chunk of those reports, which were anyway all retrospective studies, which means for me, the level of evidence is not great. And you saw the zygoma implants, I showed you more than about 15 people, big centers reporting all parts of the world, all of them having good results, which means this is a technique, not a technique sensitive procedure. Anybody can do it as long as they do it properly. So for these two reasons, I would prefer zygoma implants over pterygoid implants any day. However, I'll add a caveat to it. Today, because of digital technology getting better and getting more accessible and more economical, with digital technology, I may start using more pterygoid implants now. Because there, I've got a little more control, I've got a little more belief in that technology, and it's not as blind, we're not completely blind. So from that point of view, I would certainly start using pterygoid implants sooner or later. But until I use digital technology and guides, surgical guides, I will not do pterygoid implants.
Okay, sir. Thank you very much.
There is one more question. Can I ask, Guna? We have time.
Yeah.
You discussed about conventional. No, you discussed about conventional implants, about doing bilateral sinus lifts and waiting for 6 months vis-a-vis zygomatic implants. You know the advantages of zygomatic implants. How do they compare as far as the cost goes? If you one were to do bilateral sinus lifts and put in 6 conventional implants vis-a-vis 2 zygoma and 2 anterior implants in zone 1, you know, will it be similar or will it be lesser or more?
Actually, the zygoma implants are less expensive, even if you factor in general anesthesia. Okay, we have done an analysis. Actually, it's actually at the worst case scenario, it will be the same. It won't be more expensive. Zygoma implants with 2 conventional implants, especially when you compare the bone graft material that you have to use, the volume of bone graft material that you would use. And if you're doing sinus grafts and then you're going to load later on, you need to have minimum 6 implants in the upper jaw, nothing less than that for conventional axial implants. So here, whereas in the zygoma, you got 2 zygoma and 2 regular. So the cost wise, and okay, forget the bone graft material. What about the membrane? If you look at the costing, if you're using any of the good imported material, the Geislich material, which is the gold standard, the BioOS, the BioGuide membrane, the costs are definitely not lesser than.
So they are comparable or maybe a little lesser is what you say.
That's right, yes.
I think one last question for Dr. Ashwini is, someone has asked a question, why is there a difference in the phonation issue between fixed and removable prosthesis? Is the why?
So in a fixed prosthesis, we'll have a little space between the gingival complex and the bar. So because of that minimal space, there'll be always a phonation issue in the case of fixed prosthesis. But in the case of removable prosthesis, because of the flange covering the gap, there'll be less phonation issues. So because of the gap present, the air escape will be there and it will be causing phonation issues, especially in palatodental sounds and labiodental sounds.
Okay. And Dr. Gunasheelan, not a contraindication in smokers. Will you advise it also in smokers or?
See, far as smoking is concerned, for me, it's nothing to do with zygoma. It's got to do with the same protocol for any implant. Yes. Okay. If you would do an implant in a smoker in a conventional situation, you can do it also in for zygoma implant. So I can't go, but in simple terms, heavy smoking, more than 20 cigarettes a day, duration of smoking more than 10 years, cofactors. If they have 2 or 3 cofactors, like, for example, uncontrolled diabetes or poorly controlled diabetes, bruxism as another factor, poor oral hygiene, then it'll be a no-no. If it's only smoking, it's like any other implant, it's only a relative contraindication.
Okay. We just have time for one question now. I think that can be answered, or you and Ashwini both. Is that can a full arch implant supported prosthesis be just on 2 zygoma implants on each side, engaging just 5 millimeters of bone? Won't there be too much amount of increase in the lever arm?
Yeah, no, you cannot. With 2 implants, you can never support. You need to have a tripod support in the front. You need at least 2 implants anteriorly. With 2 zygoma implants, you cannot restore a full arch. 2 zygoma implants will have to be supported by 2 implants anteriorly or 4 conventional implants anteriorly. If not, you can have 2 zygoma implants on either side. Minimum 4 implants for the upper arch. Okay. Minimum 4 implants. I don't think we can go less than 4 implants for the maxilla in any situation as far as the instruments are, as far as the implants are concerned today.
Guna, there were 1 or 2 questions from YouTube. First one is, you said that sometimes the zygoma is only 5 millimeters thick.
Okay.
Yeah. So now, if you had a situation where you had a Zaga 4,
yes,
where you had no alveolar bone, would you be happy with 5 mm engagement of the zygoma only?
See, when we say 5 mm, I don't think 5, the width I mentioned was 7 millimeter minimum. But okay, leave it. Even you can get sometimes a thin zygoma. Okay, you get 5 millimeter. The tip of the implant that we use is a 3.9 diameter. So I have to be very, very careful about placing it, positioning it correctly. But more important is I will make sure that I emerge, distal to the zygoma. I'll have to emerge from the other cortex, the superior lateral cortex or the zygoma. So that will give me very good contact. And if I'm going to push through that, you're also lifting the periosteum. So you will get an extra millimeter of bone. Having said that, see, Balshi's study is the one that gives us comfort that even with 5 millimeter contact, he was able to restore and he had good, more than 5-year reports. So I'm comfortable if I have 5 millimeter of good bone, and if I can go through and through the zygoma, even a millimeter beyond the zygoma. You have seen situations where in the mandible, if you go a millimeter beyond the mandible, you will see some extra bone forming there because of the, the periosteal capacity to form bone. You can use the same principle in the zygoma also.
And would you ever delay load, or would you always immediately load?
That will depend a lot on other factors, primarily with the primary stability, and then depending on what the opposing arch is. If the primary stability is more than 35, I will load immediately.
Okay. The other question was regarding chronic sinusitis. What is your protocol for patients if they had a history of chronic sinusitis and you wanted to place zygomas, that zygoma was your alternative? What is your protocol for those patients?
If they have chronic sinusitis or just like polyps, etc., that's not a contraindication at all. But if they've got a recurrent chronic sinusitis, then we need to discuss with the patient and tell them just doing the zygoma implant will not make it worse. But there, the technique is important. You have to make sure that you do not land up with an oroantral fistula. That is very critical. So you have to be careful with your technique. So it's not an absolute contraindication, but you need to talk to the patient and make them understand that this is a titanium which has no deleterious effects on your tissue. In fact, once a titanium is formed, people have shown even how the Schneiderian membrane forms over the implant. So you have to talk to them, make them understand that. If you don't make them understand that, then they'll blame everything on that, not only the patient, but also the ENT surgeon. So that's worse for us because he'll say, oh, because of that, everything, they might have been, they could not have managed the patient. But then one issue like this, they'll turn the entire thing on you and say, because of the implant, everything got worse. So you need to counsel the patient a lot in such situations. It's not an absolute contraindication. Acute sinusitis is yes. You don't want to do anything in that situation. No implants.
What about post-radiation, Guna?
I will take it up in the next part of the presentation.
Okay.
It'll be covered in that.
Okay. There are some more still questions. Does your planning change when you have the patient is of younger age vis-a-vis an older age, or it remains the same as far as the zygoma implant goes? And eventually, arch,
let me think. What's up? Our youngest patient has been 17 years, 10 months. And really looking at it, nothing actually changes. No, I would only probably think a lot more on the long-term prosthetic outcome, because, an 18-year-old girl, I'll have to look, plan for 50 years compared to a 60-year-old man. So from that point of view, I'll probably put more onus on the prosthodontist on the planning. They better watch.
And one more thing, you mentioned of a Lefort 1 osteotomy advancement with a zygoma placement. So is there any modification which needs to be done for such an osteotomy? If you were to place a zygoma implant related it, or it's just same?
There is a small modification in the osteotomy because you need to have sufficient bone in the mobilized segment. You would like to do a little higher Lefort 1 than a low-level Lefort 1 because you need to have good bone in the mobilized segment also to be able to withstand the zygoma. So that's the only small modification that you have to do. So I was very impressed with the very recent, I think just 6 months ago, we saw this article of simultaneous Lefort 1 with the zygoma implants. Because I've always seen only where you do a Lefort 1, let it heal, and then do the zygoma. But this three case reports have come out of the simultaneous. That's a very interesting option.
Okay, I think we can go ahead with
last question is, should zygoma implant becomes or should be done under a GA, or is there a scope of doing under it LA when you are planning it?
I think a lot will depend on the patient and the surgeon. Okay. If it's your first case, please do it under general anesthesia. Okay, once you get a little more experienced, you can try with local anesthesia with IV sedation. Sedation is a big help. And if with the technique becoming extra sinus, it certainly is much easier to do it under local anesthesia with sedation. The intrasinus technique, I would not dare do under local anesthesia or sedation. I would do only under general anesthesia. But with the technique shifting more and more towards extrasinus technique, it is possible to do it under local anesthesia with sedation. But again, like I said, please don't do it if it's your first patient. If it's your first or second patient, try to do it under a general anesthesia, just for your comfort point of view.
Okay, I think Dr. Gunasheelan, we can proceed with the others. We'll break for your next. Thank you.
Thank you. Okay, so let's go now. I think now the surgeons will be happy, to see some technique and surgery. So this is the original Brennemark technique, where you try to, this is a path of the implant. You start from the alveolar crest, slightly palatal, intrasinus, and then reach the body of the zygoma. So you create an opening in the apex of the sinus, and then try to engage this part. This sort of exit target area. So we looked at general anesthesia or sedation. The incisions, if it's a partially edentulous, where you're going to do total clearance, then obviously it's much better to have a crustal incision. If it's fully edentulous, you can have a choice of Lefort 1 or palatal paracrustal. So fully edentulous, I prefer a Lefort 1 incision, and in a partially edentulous, we do a crustal incision. So we make the incision from the first molar to the first molar with the vertical relieving incision going up to the halfway to the base of the zygoma. So you open up the bilaterally, you have a relieving incision at the first molar region. And if you've done a Lefort 1 incision, this is how the healing will look. So you can see the advantage. You have taken the incision completely away from all your prosthetic components, impressions, etc. And so that's a huge advantage of a Lefort 1 incision. So once you made the incision, raise a flap, you would open up a window like this at what you assume to be the most superior part of the sinus. It will usually be in relation to the infraorbital nerve. So along that line, the superior most portion, you just open up a window. It's called the sinus window that you create. So something like this. You're seeing the sinus window that's created there. Just 1 second. Okay, that's a sinus window that you have created there. And then you move the membrane away. We use something like your sinus elevators to push away the membrane. And then you place your drill through from the palatal side through the sinus, and then make a small entry point into the zygomatic body. So this is your sinus window, so that when you place your drill through and through, you'll be able to see the tip of the instrument, the tip of your drill coming and making the access point for the entry into the base of the zygoma. So once you've done that, you use sequential drills to make it larger, and then you try to go and reach the outer surface. So that's the thing. You have to go from the roof of the maxillary sinus and then traverse the zygomatic body and just emerge through the outer cortex. This is a very important step because you need to get this purchase at this outer cortex. And obviously, it is not very easily visible when you're looking from intraorally. So you'll palpate, you'll keep your finger there and palpate and use what's called a hook. A zygomatic hook it's marked at 30, 35, 40, 45, 50. So you would pass through this, and with your finger held here extraorally, you can push it up. Because the skin over there is fairly thin, you'll be able to palpate the movement. And then when you pull it back, the pullback will show you what is the the length of the implant that you may have to do. For example, here it's 30, 35, 40. So I know 42.5 will be the sort of length of this implant. So it gives me an idea. So I have an idea of what the length of my implant is going to be. The critical thing is when you are doing this, this is ideally where you should be, but you can easily be a little more medial and go into the orbit, and you can be slightly a little more distal and go into the infratemporal fossa. So this is the real technicality of placing the Zygoma implant. You have to be a little careful. This is the only thing basic you have to look at. So we will look at how we can plan this based on your CT scans and surgical stents. If you do not have it, then if you're going to plan it freehand, then we'll show you some tricks how you can do this subsequently. And then, of course, you have these long implants. So the implant traverses from here, the head of the implant, it's gone through the sinus, and you can see those threads, and then it goes and engages the zygomatic body over there. So this is a placement of the implant on one side, and then you would do the same thing on the other side. So you got the implant going through, traversing, and then getting access into the body of the zygoma. And then the anterior zone, depending on how much bone is there and what you have planned earlier, you can plan either 2 or 4 implants. In this situation, we had planned 4 implants. And you see, so zygoma plus 4 implants and the lower arch 6 axial implants. In some situations where we do not need that sort of load bearing, we can reduce it to 2 anterior implants. So this is what happens at the end of a classical Brennermark technique. Because you're being intrasinus, to keep the implant within the sinus, the emergence is palatal. Your drilling would have been from there. And the problem is, this is too far palatal as far as from the arch form. The arch form is here, but your implant is emerged so far palatal. So this is a big drawback. So you can imagine the problem for this patient as far as speech is concerned, oral hygiene in this region. And then the other big factor in the long term, this is a huge cantilever. This is a huge buccal cantilever. So we need to be careful about these things in the long run. So because of this, modifications came about in this technique called the sinus slot, described by Stella and Warner. And then the commonly used technique. Today, we do not use a classical Brennermark technique much. We use more and more of this extra sinus or extramaxillary technique, which was first described by Milorenka, and then popularized by Marlowe and Aparicio and Davo and many others subsequently. So obviously, this is a much more popular technique today worldwide. So we have moved from what's called an anatomy-driven implantology to a restoration-driven implantology. So you moved the Zygoma implant from intrasinus to extrasinus. So Marlowe's study published in 2008 with a follow-up of 2 years, and then this one, the next study published with a follow-up of 3 to 4 years by Aparicio. And then one more study by Covillo where he showed that actually by keeping the implant extrasinus, the bone contact in the zygoma is much more rather than the intrasinus. He showed that there was an increased length of bone contact in an extrasinus technique and a much higher biomechanical stability than the intrasinus technique. So basically what is done here is we don't go through the sinus. We want to, for example, this is a crest, alveolar crest, and you want the processes to be here, not somewhere here. Imagine if this patient had a classical Brennermark implant, it would have come like this within the sinus and come emerging somewhere in the palate. We have moved the implant head completely outside. So we call this the extrasinus placement. So this is almost like what, if you recall, a Zaga 4, completely extrasinus placement of the implant. And from here itself, there is contact starting in the zygoma and then goes all the way into the body and then till it reaches the outer cortex. So there's good contact there. The critical thing is we have to make sure that this implant is in good contact with the bone, the buccal cortex. there should not be much gap, hardly any gap. There should be virtually grooving the anterior wall of the maxilla. This is a very important technical aspect of it. Implant is well buried in the bone, so within the bone complex. Again, here also completely in contact with the bone. This is a critical aspect of the Zygoma implant in an extra sinus technique. And see, the big advantage here is all the implant emergence is within the arch form. Unlike what you saw in the original technique where the implant was coming out here in the palate, this is well within the arch form. So much so the extra sinus technique has become the technique of choice today. And Marlowe's article on almost 474, I call it the jumbo article, 747 implants rate. And then with a phenomenal success rate of 98%. In the maxilla to get 98% success is phenomenal. It does have some drawbacks. One is the soft tissue recession because of the pull of the muscles. So you get exposure of the collar and even sometimes the implant threads. You can see the inflammation and infection setting in this place, recurrent because of this exposure. As this tissue gets pulled back by the muscle, you get exposure. And in this situation, even more. Can you see the threads exposed? So these are areas where you can get periimplantitis and recurrent gum inflammation and swelling. And from here to proceed to the sinusitis is it doesn't take too long. So this is one of the drawbacks of the extra sinus technique. And for this reason only, some of the implant systems, even the Nobel Biocare has changed the design. They don't have threads in this part. They have it as a smooth component now, a tie unite, but smooth. It doesn't have threads anymore. See another extreme situation where the threads getting exposed, almost about 10 threads, and look at the amount of plaque accumulation there. So this was another interesting modification of technique described by James Chow. It's called it the extended sinus lift technique. And he published a paper with 16 patients. Very interesting technique. So what he does is, instead of creating a small window, he creates a large window like a large direct sinus lift. People who have done a lot of direct sinus lift will understand how this works, because if you have a large window open and the membrane intact, there's a good possibility that you can form bone later on. So the membrane and the bone window is pushed medially, and then the implant is placed. So it becomes a combination of an extra sinus implant placement. To me, this is the best option. If you can get a nice big window and push the membrane away with the bone intact, place the implant nicely, you get the best of both worlds, the intra and extra. It's well within the bony window, bony arch. And then you're going to put back the flap, which is mucoperiosteum. And then this is be like a large sinus lift. And actually, James Chow showed almost 50% of this forming bone subsequently. In subsequent CT scans, he showed that almost 50% of this area was filled with bone. So you can imagine, because it's like a direct sinus lift, and you do not have to place any grafting. So this, we call it the extended sinus lift. It's like an extra maxillary technique, but this has the best of both worlds. So this will be the ideal technique for us. But having said that, from a restoration-driven implantology, prosthetically driven implantology, today it's aesthetics-driven implantology. You do not want this, right? You don't want to see this sort of a picture. So but I'm going to talk through some complications as I'm going through instead of keeping it only at the end of my presentation. So this was a real life situation where I learned it the hard way. That's why I respect my planning and my prosthodontist more now. I went like a usual cavalier surgeon. Okay, come on, open up free hand. Let's do what we want. Put the implant and let the prosthodontist handle. And my prosthodontist showed me this. It was mortifying. So I had to take the patient back to surgery, take off these two implants, anterior implants, do an ostectomy. And you can see that this implant is still there, and you can see there'll be a step, but at least the aesthetic zone will not be visible anymore. But this was a big mistake that I made in our first few cases. Not planning well enough from the vertical point of view, from the smile line point of view, from the transition zone point of view. So it's very critical that we look at it, from the aesthetic and the prosthetic point of view before doing the procedure or planning the procedure. So subsequently, of course, we could get the 2 anterior implants in at a much deeper level. And then we moved from here to here. But this was at great cost. So please don't make this mistake. What do you do when zone 1 also has no implants? We talked about the Bedrosian zone 1, 2, 3. Zone 1, the anterior zone has no bone. Then you have to put 2 Zygoma implants on either side. So again, not very new. It's published first in 2007 with good success rates. And then 100% success rate on 17 patients done by Davo. So once we started seeing more publications coming on quad zygomas, then we said we should also plan. I mean, look at this extreme resorption in this situation in the maxilla. Posterior maxilla, hardly any bone there. Anterior maxilla, also 1.7 millimeter diameter, thickness of bone. You had enough height, but see the thickness is 1.7 on one side and 2 millimeter. No implant can be placed in such situations. Agreed? So you need to either bone graft or this is anterior zone. So the option then would be to do a quad zygoma. So the planning is to do quad zygoma. So we used a denture. At that point of time, in the first few cases, I just used this as my mark, just to show me where my canine is, and then my second premolar. You can see the punch, just for me to have an idea where I should locate the emergence of my implant. And you can see there is so much of resorption, buccal resorption. So this was the original position of the alveolar arch. So much of resorption has happened. So if I had looked at this position and placed my implant here, my abutments would have come here, my teeth would have been there. So this is a very simple guide. Use a denture to know where your position is in the central fossa of the second premolar or the first molar. You can mark it and then plan your freehand surgery. So open the flap, identify the nerve very clearly. You got enough bone on this side. And you know from your pre-op cone beam CT, you have already analyzed the thickness of the zygoma, lateral, mediolateral, and also the length. Yeah, and the length is going to be about 14 millimeters or so. So you would place one implant anteriorly and one implant posteriorly here. So you can see the posterior implant. You can see the tip of the distal end. I've gone through and through the other cortex. And this is the other depth gauge, which shows that's also gone through. You need to maintain at least about 2.5 millimeters between these two implant apices. So you can see that this one is completely extrasinus and this one is little intra and little largely extrasinus. So the planning will let you place these implants in a little more balanced position. Anterior posterior spread can be planned well if you have a denture beforehand. And then you place these 4 implants and a full arch prosthesis. Again, you can see this makes a big difference when you have the implants well positioned anterior-posteriorly. Not an old patient, right? Quad zygoma for young. Most of my patients are less than 40 years today. Now, this is another mistake that we made, learned it the hard way. We found an infraorbital nerve, which was what should have been the normal premolar position, was completely laterally placed, about almost 12 millimeters more lateral than the conventional position. And I had planned a quad zygoma for this patient, opened up, and I knew, look at the bone here. There's no space. I mean, there's enough bone everywhere in the zygoma. We had planned everything. We had not calculated the position of the infraorbital nerve. So today, if I plan a quad zygoma, I will insist on my radiologist giving me the position of the infraorbital foramen. Okay, So these are two cases like this. We have got an abnormally positioned infraorbital foramen, not reported in the literature yet. But this is very interesting. See the other side on the patient, see again, hardly any bone. I mean, there's no way you can get two zygoma implants here. So one zygoma implant. So anteriorly, I had to go and modify my plan and put bone graft, place two implants, go get a floor of the nose purchase for the anterior implants, bone graft, membrane, close it up, and delayed load. So cut a sorry figure because we had told the patient, yes, if we get primary stability, we'll give you immediate prosthesis. No way you could have given a prosthesis for this. Bad mistake, but we didn't know. So today, one more thing I asked my prosthodontist is to tell me the position of the infraorbital nerve, which normally we never look at because we assume that's the standard position of the nerve is in the second premolar region. We never bother about it. The radiologist will not report because it's not relevant. But for a quad zygoma, it's very, very important that you know the position of the infraorbital foramen. Now, a zygoma implant can also be used for partially edentulous situation, although there are not many reports yet. But we have had about 7 patients now with this sort of situation, posterior free end saddle, zygoma and one implant. So that works very well actually, because the anterior teeth are very good for the patient. So a posterior zygoma with the regular implant and a bilateral free end prosthesis. Okay, another big disaster for me was when we had a patient with severe cleft maxillary deficiency. And then we planned and we said, okay, we'll have a prosthesis and say 2 implants and we'll do an overdenture. We'll try to get a second implant on one side. So we had planned and then we said, okay, we did this planning and went ahead and did the procedure. So you can see that this is, again, lot of implant, almost like an extra sinus. But the problem we didn't anticipate was that this particular patient had heavy occlusal forces on the lower on natural teeth, and this implant and she just disappeared. She didn't come back for almost 8 or 9 months, and came back with a fractured implant. So this was the only case that I had with a fractured implant because it was not properly planned. We didn't do the biomechanics properly. So you have to be very careful when you have these sort of situations. See, this is the other side. Even though we had got very good purchase, see, I've gone outside the cortex there. So when we had this implant, the overload situation fractured this implant. So we need to be careful that we keep very constant tabs on these and follow up on these patients. You were talking about radiation and mid-phase rehabilitation and partial maxillectomies. So these are a couple of good articles. Landis's article where he showed a success rate of almost 90%. And this is done after about 3 months after radiotherapy. You wait for 3 months. And then he usually does 2 implants on either side, and sometimes 3 implants also on one side. And he had good results, 90% success rate. On the contrary, Boyce Warley had a protocol that they would place the implant at the same time of the tumor resection, simultaneous, which makes it much simpler. And if they needed radiotherapy, he was suggesting that we give the radiotherapy 8 weeks later. So he reported on 20 patients with a 1 year to 8 year follow-up and 100% success rate. But there are a lot of other studies which are coming, which are only in the range of about 90%. You never get this 100% success rates. But this protocol for me is more attractive because you do the implant placement at the time of resection. So this was a patient who had subtotal maxillectomy, and then he had 4 implants placed. And this was our first patient, so obviously we didn't get this the planning very well. So we had 4 implants, but actually we could load it on 3 implants only because the 2 heads of the implants were too close for me to fully utilize. 4 implants placed, all integrated, but we used only three implants for to making a bar. So this is a fixed bar retained overdenture. So we had an overdenture with the O-rings, and then rehabilitated this patient with an overdenture. So this works very well with the 3 or 4 implants. We can't do it with 2 implants. We need minimum 3, ideally 4 implants to restore a maxillectomy defect, because your processes will be a little larger. And I've not done any restoration for total maxillectomy. So this patient is courtesy of Dr. Anjan Shah, was kind enough to give this and said, people might be interested in seeing. So this is a very good result that you're seeing with the 4 Zygoma implants and with a very nice framework, and then an overdenture. So these are very satisfactory ways of restoring maxillectomy, partial or total maxillectomy defects. For me, another huge advantage is using Zygoma implants as a rescue procedure. You see this sort of patient who comes with a failing bridge and some broken implants, etc. You get rid of them, place 2 Zygoma implants and 2 anterior implants and restore them simultaneously. This is another patient who came with this sort of a situation. Somebody who has been very optimistic about restoring this maxilla with just 2 implants. So we, absolute disaster. So we had to take it off. So that's a intra-op position. Remove the exiting implant, did a curettage, do an alveoloplasty, and then 2 anterior implants and 2 Zygoma implants. So here you can see the different design of the implant, which has got the smooth surface. This doesn't have threads, so that if it gets exposed, also you do not have too much of hygiene issues. So you see this smooth surface, tie-unite surface implant. So this is an advantage of the newer designs of the Zygoma implants. So this is a great rescue procedure for patients who had problems with conventional upper arch processes which are failing dentures. I'm going to wind down with the guided surgery option, but true guided surgery for Zygoma implants cannot happen because it's not intra-bony. We know that true guided surgery can happen only if your implant is going to be completely bound by bone. Here we saw most of the techniques are becoming extra sinus, which means some of your implant is going to be touching soft tissue. So you cannot do guided surgery. So I call it a semi-guided surgery. For example, here's a patient who's got pretty mutilated teeth. So we planned a quad zygoma. We're going to remove all these implants. So we use some 3D software. We've got multiple software, third-party softwares, Nobel clinician software. You plan it, and then you want to make a surgical stent which is bone-based. A bone-based surgical stent is what we are planning here. So this is done by Dr. John Nason in Chennai. He does wonderful work with this technology. So using this bone-based guide for a quad zygoma, you can place these 4 implants. For me, a stent is crucial when I do a quad zygoma because you cannot afford to make a mistake. In a single zygoma, you can sort of make amends, but if you get this a little closer or if the apex comes too close, you're finished. You can't get a second chance. Certainly not at the same surgery. So having for a quad zygoma to plan and have a surgical stent is really worthwhile. So, so you get good positioning, good spacing between the apices. You cannot get this freehand. I mean, you may get with a lot of experience, but even then, it's not a substitute for this technology. So use technology when you should, and you can. And today it's available. So that's a patient with a quad zygoma. Certainly, you can also use it for conventional. If you're only doing 2 zygoma, 1 each and anterior implant, you can still use it if you want to be very, very precise from the position point of view, especially at the insertion of into the zygoma. So you can use bone-based stents even for single zygoma on either side. So this is how we would normally do with the Nobel clinician software. Yeah, I think I'm going to rush through because a lot of you do digital planning. It's the same thing. You merge the radiographic guide with the bone, and then do the virtual planning. Look at the emergence. Look at the abutment positioning in relation to the single anterior teeth, and then look at this position also, canine and then the first molar position. So you have a fairly good idea of how you can distribute these the implants and make your stent. So I've come to the end of the surgical part, and I just wanted to touch upon the semi-guided procedure because that is very helpful in quad zygoma situations.
Yeah. Yeah, plenty of questions, Guna.
Okay.
Okay. First is you discussed different techniques, right?
Yes.
And so which you alter your technique depending on your Zaga classification, or you prefer to go extra-maxillary nowadays most of the time?
Today, I don't look at the Zaga classification as much. It's a guide. I use it as a guide. I know, okay, where am I going to be roughly. But I would rely in a quad zygoma on a stent. If not, I would rely on a existing denture, at least to know the point of my entry, where my implant head has to be. I like to look at that position, and then almost completely rely on the extended sinus lift technique as described by James Chow. It is, and it's all, it's different names. It's called extra maxillary, extra sinus, extra, extended sinus. It's all splitting hairs. But you saw when I described the extended sinus, you get the best of both worlds. You're trying to preserve the membrane. It's nice if you can have an intact membrane. It's not mandatory, but if you can have the membrane intact, it's great. If you can have some bone medially, that's also nice. So the extended sinus lift gives me the option of the best of both worlds, intra and extra sinus. So I prefer the extended sinus technique as a technique of choice. And I'll try to show you a video at the end of the presentation where you'll also see how it really is. It's so
you mentioned about the sinus lining. Now, when you make a window, do you reflect the entire sinus lining? And in case you are unable to do so, is it a matter of concern or use some membrane to block it or what?
Yes, if it's not a matter of concern, we try, but almost 50% of the times the membrane tears. If it doesn't tear during your elevation, and it tears sometimes when you place the implant or when you're drilling the bone. So you try to push it away and hope for the best, but it's not mandatory, but you try. You always try to keep the membrane intact. But if you have a perforation, then very close, if the perforation is very, most superiorly, I'm not too worried about it because it reforms very well. If the perforation is closer to the alveolar crest, then I'd like to put a membrane there. I'd like to put a resorbable membrane, or I'd like to put some PRF there to seal it off.
Okay. Well, one more question on your planning. When you do plan, your point of entry is your second premolar or your first molar. If you're doing a single zygoma, where do you plan the entry point normally?
As far posteriorly as possible, because you want to reduce the posterior cantilever. In most of the times, it'll usually, you'll be lucky if you can get it at the first molar. It is usually in the mesial part of the first molar or the first molar, second premolar junction, or even the second premolar. Any of that region is okay, but your aim should be to go as far posteriorly as possible. And that is where your mouth opening becomes critical. You need to have really good mouth opening to be able to get as far back as the first molar.
Okay. One more thing is, when you're putting a quad zygoma, I think you showed you go simultaneously on both the implants, right? You don't put one implant and then put the other, or how? You do the osteotomy for one and then do your osteotomy for the other also, right?
Correct. Yes, that's right. And then place all the implants together.
So which do you place first, the distal one or the one which is behind?
It's your choice. I like to place the distal one first because you go right up to the posterior wall of the maxilla, and I want to make sure that my posterior implant is really far back, and then place the anterior implant. But having said that, the reverse also works very well. You can do the anterior implant and then do the posterior implant. And the reason why people like to do the anterior implant first is because that is going to be coming very close to your orbit. So you need to be very, very careful about that anterior implant because that's going to go very close to the lateral wall of the orbit. And people have made mistakes there and gone into the lateral, part of the orbital wall and produced transfixation of the lateral rectus and the inferior oblique muscles. All these things have happened. So that the anterior implant is more critical from the anatomical point of view. So they want to put that anterior implant first. But this is, again, like I said, this was very critical during the intrasinus techniques. But with the extra sinus and extended sinus technique, I think doing the posterior preparation, anterior preparation, doing the posterior preparation first and keeping an instrument there to get your, your position, and then doing the anterior implant, site preparation is not a major problem.
And what should be the distance between the two implants, approximately?
At the apex, at least 2.5 millimeters, 2.5.
Doctor, do you do any grafting? Suppose you made a big window for your while putting the implant, and
Yes.
At the alveolar crest you feel some implant threads are exposed. Will you like to graft that area with a membrane, or you can just leave it that way if there's palatal support?
Yeah, again, a very good question. I am more careful about soft tissue, the membrane being intact. If the membrane has a perforation, try to seal it as much as possible using PRF and resorbable collagen membrane. I have tried putting particulate bone and then sealing it, closing it off with PRF, and then closing it with a membrane, and then putting a mucoperiosteal flap back there. Within a short while, everything disappears. Okay, so nothing stays. The bone doesn't stay there. The better thing would be to see if you can mobilize some buccal fat. Take some buccal fat, because that's abundantly available there, and that can be layered over the lateral aspect of if the threads are exposed. That actually helps much better than anything else. No bone graft, it doesn't help.
Yeah, Nitin, you can take over and ask your question.
Yes, sir. So the first question is, can rough surface implants be used for extra sinus and extra maxillary technique?
Ideally not, because of this issue of when you have recession, that's going to be a huge hygiene issue and plaque accumulation. Better not to. Use a machine surface or a relatively smooth surface. For example, a tie unite is as good as a smooth surface, but it's got better soft tissue integration. So you do not want a rough surface or even a thread design at the level of the crest.
Yes, sir. So next question is, can 2 zygomas and 2 pterygoid implants be used for full maxillar reconstruction?
Good question. Technically, yes, as if you've got your zygoma implants coming at the canine region. If you can get the zygoma implants at the canine region to form the anterior support, and the pterygoid implants are going to be your posterior pillars, 4 implants, technically, yes, should be possible. But I've not done it. I can't recall of any reports like that. But I don't see any reason why it can't be. You can.
Yes.
But you can't do the zygoma implant in the second premolar region and put the pterygoid implant and then cantilever all the way to the anterior. That is not allowed, because you don't have the anterior posterior spread. That will be a problem.
Yes.
If you're doing that, you have to have the zygoma implants emerging at the canine region.
Yes, sir. Yes. Sir, I'll add to this. I have done a case like that, but then what I did is that I have not given a prosthesis from pterygoid to pterygoid, because the more the distal contacts comes, there is a anterior pull. So I have placed like the zygoma in the region of 3 and pterygoid in the region of maybe 8 or mesial of 8, but the prosthesis was 6 to 6. That is,
I agree. Yeah, that's a sensible thing to do. Yeah, I fully agree with that. That's a good, good option.
Yeah. So next question is, can heavy occlusal forces damage the implant? Like, because there is a long cantilever, and whether there's a chance of breakage?
Oh yes, certainly. Yeah, certainly they can damage the implant. They can damage the abutments. They can damage the prosthetic screws. Yes, and they can certainly fracture the implant. So much so now. Some of the systems have also come out with a little larger diameter implant, a 5 millimeter diameter implant. But for me, I'm not comfortable with that, because if you have 2 5 millimeter implants for a quad zygoma, I don't find enough bone. So I am very, very uncomfortable. So, but just for this reason, because of fracture problems, they have actually come out with the larger diameter zygoma implant also.
Yes, sir. Sir, and the next question is, do you need a fibula or something for support when you put a zygoma implant post a maxillectomy case?
People have used it. They have tried it with also fibula support. Yes, it can be done, but it's not a mandatory especially when you saw the pictures that we showed you, both my case and Dr. Anjan Shah's case, where you have a framework which is fixed, and then you have an overdenture option. In such situations, it's not necessary.
Uh, Sir, is there any difference in prognosis of smooth surface versus threaded zygoma implant, and the chances of peri-implantitis in a threaded rough surface implant?
Certainly, the prognosis part in long term, I don't think there's any proper prospective study conducted. But as far as peri-implantitis is concerned, definitely there's a difference between a smooth surface and a rough surface implant. Surely, it's much better to have a smooth surface design. At the crest, the thread is obviously in the zygoma region, the apex, but at the crest, a smooth surface design is better.
Yes, sir. How is the angulation of zygoma implant determined, and how much is maximum angulation which is allowed?
The zygoma angulation is usually about 45 degrees, usually. But if you have more resorption, it will be more. So it can go up to 55 or even 60 degrees. That is why your implant can have either a 45-degree angulation. That's between the body of the implant and the crest of the implant is usually a 45-degree angulation. And if you need further correction, you correct it by using different angulation in the abutments. You either have a 0-degree or a 17-degree abutment. So you can correct. So for example, 45 plus another 17 degrees. So you can correct up to 62 degrees with the abutment also. So combination of the implant head versus the implant body, 45 degrees, plus the abutment, multi-unit abutment also can give an extra angulation to help you correct it.
Yes, sir. Sir, any study where bone graft has been done in CHAW technique, where large bony window was made and intra and extra sinus approach is used?
James Chow showed good bone formation on post-op CTs after a year without any grafting. But having said that, there are some reports from Australia. They call it as he calls it the Zygoma Plus technique. So what he does is he does the same thing. He does all the extra, the extended sinus, lifts the membrane, makes it intact, and grafts at that time, like a direct sinus lift. So his principle is, tomorrow, if I have to put an extra implant posteriorly or something, I already have, I've built up bone for it. So he has grafted it, but I've not seen that publication. I've heard his lectures and I've seen him present on that, but I've not seen any publication to that effect. He calls it the Zygoma Plus technique.
Yes.
He does the same thing for all-on-4 also. He calls it the all-on-4 plus technique.
Yeah. So next question is, what is the solution for a patient who is not having a good mouth opening, but is having an atrophic jaw, like requiring the zygoma implants? So will it become a contraindication in such case, and how will you solve it?
Absolutely, you cannot do it, because today's instrumentation is such that you need to have, for me, I calculate about 43 to 45 minimum mouth opening to get the posterior part of the implant. You can't do a zygoma at the canine region and then say, let's do restoration. You can't do it. So for me, that's definitely a contraindication. So you have to look at some other option.
Yes.
You have to look at some other option.
Okay. So next question is, how helpful is Zygo Guide by Dr. Dan Rosen?
See, Zygo Guide is, like I was saying, it can only be used as if you want to do an extra sinus, you cannot use a full guide procedure. If you're doing an intra sinus procedure, you can do a guided surgery. But my concern, yeah.
Sorry to interrupt. Sir, this is an instrument actually. The name is Zygo Guide, but this is actually an instrument by a American doctor who operates in Brazil, but Dr. Dan Rosen. So basically,
Rose. Okay, what does he do with it?
Yes, sir. So you attach your drill to your handpiece, and then there is a simultaneously one long end of an instrument which is engaged exactly parallel to it.
Yeah.
So you have an idea that where exactly you are going, like you are going towards the orbit or not. If you have seen that, so if you can comment.
No, I've not seen that actually, but I can understand that. It's almost like what we would do with, those the medial retractors for your the sagittal split osteotomies.
Yes.
We used to have those medial retractors with a light source, and then your drill will go only in that direction.
Yes.
So you're not going to miss anything. So you got visibility and you got the rough position. I can relate to that. I think, yeah, it is a good option. I've not seen it though.
Okay. Next question is, any incidence case of zygoma implant failures? And if yes, how you have managed it?
Yes, we have had Zygoma failures. So our own rates have been about 97. So we have got a 3% failure rate. So when we have failures, one option is, what we have done is we have come back and redone it after 6 months. That is a possibility, and then we'll make sure you don't make the same mistake which caused the first problem, which is overloading. So we delay load in the second stage. We don't do immediate loading, and we come back and we can redo it about 6 months later. A redo procedure is possible. That is described in the literature. We have done one surgery like that for a failed case.
Okay.
A couple of patients where we had a fracture, we had to completely drill out that implant. No other way. And we'll come to some other complications in my next section also.
Okay. Sir, now one more. Angulation of zygoma implant detected by CBCT, and how will you measure?
That can be measured on...
Like on CBCT, that, this is the angulation which most commonly, yeah.
You can. I mean, based on your software, you can easily measure the angulation of the implant, and you can choose your abutment accordingly, because unfortunately you don't have the choice of too many implants with different angulations, but you've got abutment angulations, and you can choose to see where it will emerge. It is possible on software, on the CBCT.
Okay, sir. Next question is, with advanced imaging techniques, is it possible to do flapless without raising the flap?
See, my thing is, okay, let's look at even like something like, say, navigation. Yeah. It is possible. It is definitely possible. But the problem is, all these will work if you're completely within bone, which is like the intrasinus technique. But we have seen that in the intrasinus technique, the biggest problem is the emergence of the implant is going to be a little more palatal, which is not ideal from the restoration and maintenance point of view. And when we bring the implant outside the bone, then we cannot do fully guided surgery. It's not possible, because you will completely macerate the periosteum and soft tissue. We have to raise a flap. So it cannot be a fully guided surgery. That's why we call it a semi-guided surgery.
Okay.
Okay. Can I take some YouTube question, Nitin?
Yes, sir. Yes, sir. Please.
Yeah. Yeah. One question is, how do you diagnose a heavy occlusal force in an edentulous patient? And when you have such a patient with strong musculature or a patient with bruxism, would you still load it immediately or prefer a delayed loading?
Bruxism, I think we start right from the history, right from loss of teeth. If the patient has not given you a history of periodontitis or trauma and he's lost teeth, you can fairly assume that it is because of forces, extraocclusal forces and bruxism. Then you look at the patient, you will see the patient's masseter. You ask him to clench and you can see how he clenches and see the forces. When you ask them to do a jaw relation, a test jaw relation, you will see the forces. And I've seen patients who bite so hard, your bite rims completely gets, squished down. So I know there are some things to measure and measure the occlusal forces. There are some occlusometers, which can measure it. I've not used it. I go by the history and going by the clinical features. If you have this and the habits, if they're pan chewers and they're chewing on nuts, that they have ground down the teeth, they'll have those extra force of chewing. In such situations, I would not immediately load. 1. 2, be very cautious about, taking the patient, get them really educated and say, if they want this option, they need to stop those habits. And if necessary, we can look at an overdenture option. Try to convince them to go for an overdenture option. Always try to make them wear a soft guard or a night guard. And then, if possible, also inject a Botox injection into the masseter. That also has a very good effect for at least about a year. So these are the ways I would handle a bruxism patient.
Okay, one more question is, when you place the implant extramaxillary, is this implant palpable in the maxillary vestibule? And in case of exposure, do you consider some soft tissue grafting in such cases, or how will you manage them? When there is,
it's
you showed some resorption
sure,
of the gingiva.
Sure. Yeah. It's hardly palpable because you've got a good mucoperiosteum over it. And if your implant is fairly good contact with the bone or even little embedded in the alveolar crest, I've not heard any patient who complains that they can feel it or palpate it. So that never happens. But once the exposure happens, none of the grafting works. You can put any type of, you can put connective tissue graft, you can put buccal fat, nothing stays on that after that. You just have to maintain it in the same position, maintain hygiene. No grafting works in such a situation.
Okay. And one more, you showed a couple of abnormality in suborbital nerve. So if you have the anterior wall of the maxilla, which is very thin, does it really hamper in any way, or it doesn't matter?
It doesn't matter. You just have to be a little extra careful. Like, for example, you open and you see it's almost a translucent anterior wall. You just need to be a little extra careful when you use your drills to open the window, because you don't want to go through and perforate a lot. You need to just be a little careful, that's all.
Okay. One more thing is, if while putting a Zygoma implant, you get a very less loading, would you prefer to do it as secondary? I mean, you get a very less torque and you don't get great stability. You'll prefer to load it at a later date? Will that improve your chance of osseointegration?
Absolutely. Absolutely. Sometimes you get 10 Newton, 15 Newtons primary stability. You just delay load it, 6 months later, you can load it. There's no issue at all. Like any other conventional implant. But having said that, if you get good stability, if you get 35 Newton stability, you should preferably you should load. People are showing that you get much better long-term results with immediate loading rather than delayed loading. Zygoma implants.
Okay. And can two zygomas, one on each side, be used for an overdenture?
No, we cannot. You need at least one more implant anteriorly, preferably 2 more implants, but at least one more anterior.
Okay. And one more question is, when about your exit in if there's an all on 4 or 6 implant, will it change? And can you comment a little bit on the AP spread when you have all on 4 or 6 implants in the maxilla?
You need to have, at least a 20 millimeter from the midline to the emergence of the posterior implant, at least 20 millimeters AP spread. That's what will bring you to almost like the second premolar region. So you need to have that much at least, that sort of AP spread. And that's why most of the all-on-4 guides, you'll see they will have some markings, at 7, 14, 21. So if you have the 21 millimeter mark, you've got sufficient AP spread. You'll have the laser markings on those.
Okay. One more question is, Dr. Ashwini, the question is that can we give unsplinted ball attachment on Zygoma implants, or it always a bar with a ball?
Yeah. So the success of the Zygoma implant process is,
I think little louder, ma'am.
The success of the Zygoma implant process depends upon the cross-arch stabilization. So always a splinted process is better than an unsplinted process. So we have to give a splinted bar with any ball attachments or even a locator attachment. So a splinted process is always preferable in a Zygoma implant process.
Okay. Thank you. Nitin, do you have some more questions on Zoom?
Yes, sir. Yes, sir. One good question. Now, today we have a subperiosteal implant, which is way better than what we used to have earlier. So compared to a Zygoma case, the kind of training which is required. So what would you recommend, like going for a subperiosteal implant, which probably will be 3D printed or used with the additive manufacturing technology, compare a case, the same atrophic case, you will do it with a Zygoma, a quad Zygoma?
a customized subperiosteal implant could be certainly an option. Certainly an option, because then your framework can go and encompass up to the zygoma also, long enough. I mean, big enough to go along the anterior wall of the maxilla, and maybe a little towards the palatal side. A custom-made implant is certainly an option. But my concerns are two. One, vertical positioning. You know, you remember how much emphasis I was putting on your transition zone and the lip smile line, etc. That you will not be able to control, because the bone is going to control the position. You're not going to remove any bone. You're not going to be able to control the vertical dimension. That is one. Second issue is, if you have an infection, see, this was a problem also in the earlier subperiosteal implants. If you have an infection at one part of the implant, it's going to spread along that very, very fast and easily. So that is my other concern. How do you control that? You know, we can't go and take off part of the implant later on. Whereas in all these things, you've got all are different implants, and they're splintered outside, whereas the control is yours. So if there's a problem with one implant, you can always go ahead and change it or convert it or make it a shorter, you know, arch or whatever. In a custom-made implant, those will be big challenges. And then what will be the cost aspect also? Because my feeling is that will also become a little more expensive. So these are my concerns as far as for a full arch custom subperiosteal implant is concerned.
Yes, sir. Sir, next question is, if we are drilling towards orbit, what is the immediate complication that we will encounter and what to do with that?
If you're drilling to the orbit and you realize it immediately, maybe you're not done enough damage, because you won't place an implant in that place. Because the problem happens is not with the drill, because most of the drills have some design to, you know, to protect the advancing tip, so it won't damage it. It may produce a little bleeding, maybe a little hemorrhage into the orbit. You of course be careful with that, because if it builds up a lot of pressure, then you have to be watching out for the next 48 hours or so. And there have been one report, if I remember right, where it led to increased intraocular pressure, and they had to go and let out the hematoma as an emergency measure. But if you don't realize it, and then if you placed an implant on top of it, that is a problem, because then you can go and produce irreparable damage to the muscles. You know, there are reports where the lateral rectus has completely been encompassed with the tip of the implant, inferior oblique getting anchored to the implant. And by the time later on they realize, and you know, the patient has got a lack of movement of the orbit, then even if you go and take out the implant, the damage is done. They don't recover. So that is a problem. So you need to, if you're identified at the stage of the drilling, see, that's what you can make out when you use these small instruments that you check. You go through the osteotomy site and feel. You should feel that on your finger under the skin. If you don't feel it, and then you will see if it's going medially, then, and if you feel again it's going into some soft tissue where you cannot feel it, it's either in the infratemporal fossa where it's deeper down, or it is into the orbit. So you can see by the general direction. So you need to be extra careful in that. And if you have a doubt, just don't place an implant there. If you feel you're gone into the orbit, you change the direction and go into another spot, another place. But that is where a quad zygoma becomes difficult, because you will not get enough bone to place it again. If it's a single implant, you may have some bone to go further distal and place an implant.
Yes. Sir, which patient will require 3 zygomas? You mentioned.
Usually it will be maxillectomy type of patients.
Okay.
With large cantilevers, long vertical, custom abutments. Because once you have increased vertical dimension, then the forces are even more. So those are the patients who require, usually maxillectomy patients.
Yes, sir. So what are your views on the zygoma in Indian patients compared to European and Chinese, where you will get more publications from? You have found out any difference, like Indians have a thinner or
Yes, I've definitely seen, this, the dimension that they are talking about, 7.5 to 9.5 as a routine. I've certainly seen much lesser than 7.5 in a lot of patients. Certainly much lesser in the syndromic patients.
Yes, sir.
Syndromic patients, the bone is definitely lesser, I've seen. And the abnormally placed infraorbital nerve. That's another thing that I've seen. I don't know if I've not seen it in literature, so I don't know if it's available. I mean, it's the same situation in some of the other populations. So this position of the infraorbital nerve this is a third thing that I've seen different.
Okay. Do you use intraoral welding in picking up the provisional dentures?
I don't. Ashwini, do you want to answer? I mean, we don't do it in our center, but Ashwini, do you want to talk on that?
Yes, sir. Hello. Yeah,
Yeah.
even the synchrotization process where we do intraoral welding of implants is not advisable in most of the patients because of presence of saliva in oral environment. A completely dry environment is not possible, which gives the success of synchrotization. So I suggest normal pattern resin slitting will be enough for slitting all the impression copings in a full large processes.
Okay.
And
Yeah.
cost factor for the equipment is to be considered.
Yeah. Okay.
Couple
So
of,
what is the speed? Okay.
Sorry. No, go ahead. Anything, go ahead.
Yes, sir. Last two questions. on Zoom.
Okay.
Okay. So what
I've
is
got
the
some more.
speed for drilling? Speed for drilling.
The initial drills, I'm a little higher speed around 2000, and then I drop it down to about 800 RPM with high torque.
Okay.
The final drills are around 800 RPM.
Yes, sir. And the role of C-arm while placing Zygoma implant?
I have not personally used it, but I think the radiation dose doesn't warrant it. It's high radiation for what benefit you're getting. And especially if I can see it in an extraoral technique, I can see where my implant is going visibly. So I would not,
Yes.
I don't need a C-arm. I don't think there's any role for C-arm in extrasinus implant placement.
Okay.
On the same note, Guna, do you feel in the future there'll be a role for intraoperative navigation to drive in Zygoma implants so that you don't get into this intratemporal fossa or into the orbit?
Absolutely.
That could be the future?
Absolutely. Navigation will certainly have a role. No doubt about it. Navigation will certainly have a role in the future to make it more predictable and safer. Yeah, for sure.
Okay, one more question. Suppose if hemimaxillectomy is done, can we put a quad unilaterally and do denture rehabilitation?
What is that question? Quad unilaterally, four zygomas on one side?
I mean, two zygomas on one side and do a denture rehabilitation for partial maxillectomy, hemimaxillectomy?
No, you need to have one more implant anterior as an anchorage. You can have two zygoma implants, say, for example, in the, emerging at maybe the resected sort of canine region, but you can't put a cantilever anterior to it. You need to have one support. Sometimes we, in fact, go and extract a tooth on the other side and put an implant, a regular implant, and then connect it to the two zygoma implants. You need to stabilize it across arch.
Okay. One more, since we are on surgical technique, has it ever happened that you had to abandon a zygoma procedure, a zygomatic implant procedure in your vast experience? Intraoperative?
No, no. As abandon the procedure, no. But I've had to modify because of problems like damage to the implant head. I had to put, keep it as a sleeping implant and put another implant. And I've never had to abandon the procedure. I had to modify again when I had planned a quad and I found this nerve too far lateral. I had to convert it into a single zygoma implant and a bone grafting situation. I had to modify procedure, but I've never had to abandon it.
And one last question before we go on to the third part is, does skin marking help when you mark on the zygoma, exit point of the zygoma, and how much distance from the lateral orbital rim should be the exit of your first zygoma implant?
You have to be as close to the lateral orbital rim. There's no, you can be very close to lateral orbital rim. Skin marking has no role in this at all. What we do is we keep a reverse bevel Langenbeck in the notch. And that's an excellent tool to give you an idea of where we are going. So, and keep as close to the lateral orbital rim, but skin marking has no role.
Okay, I think we can go on to your third part of your.
Sir, one question, sir.
Yeah.
Yes, sir. So, role of STL model, do you do for your surgeries? The 3D model? Yeah.
The 3D model, sometimes we do for the patient education for them to understand. And also in the earlier days when they used to make this stent, the bone-based stent, they used to make these STL models. But today they also do that on virtual models. They don't make the model for the stent.
Okay.
So I don't use it extensively nowadays.
Okay. And sir, any instruction which you give it to the CBCT center, like if the patient is not visiting your regular CBCT center, if he's not from your city and he calls you and you have advised him a CBCT, so any special instruction what you give to the patient or to the CBCT center?
No, I just make sure that the machine has a proper FOV. We have to make sure you have at least a 10/12 field of vision, because some of them are not calibrated for that. That's the most critical one, not anything else.
Okay, sir. I think we can start the third session.
Okay. All right. Thank you. Okay. Okay. Okay, I have this video. Let's run the video for 10 minutes and then I'll continue with the complication. Is that okay?
Fine, that's fine.
Okay. I should have finished the video. Anyway, it doesn't matter. Okay. So here you will, here's a patient who's intubated terminal dentition. You can see the mobility of the teeth. They were going to do a total complete extraction. I think we had planned extraction and two regular Zygoma implants and two anterior implants. So because this is an extraction and immediate placement, we have got a mid-crestal incision. And then you can see the buccal release over there going towards the zygomatic buttress and then subperiosteal elevation. So now we are doing the alveoloplasty. I usually use a nice vulcanite trimmer to get the bone. This is part of the vertical reduction that I told you. We had planned whatever vertical reduction we need. If this, and then evaluate the inter-arch space. So I want to, if you remember that I had planned, we need at least about 16 to 17 millimeters of space for each arch processes. So from the upper bony rim to the lower one, I want about 34 millimeters. And if it's not enough, then I would go and remove some more bone. So you can see that this is well under the cover of the lip also. So once I'm happy with the inter-arch space, then we can start planning for the implant site preparation. So I use a vernier. So you can see the infraorbital nerve there as a marker. And see, I use my finger pressure here as I elevate the flap, use a Howard, as I'm stripping off the periosteum on the zygoma. I've got an external control on the zygoma as well as the lateral orbital rim. So I know I'm not going to go very close to the lateral orbital rim. That's very important. When you use the periosteal elevator, you've got a tactile control here. And this is exactly where I'll be placing the reverse bevel Langenbeck, and it goes into that position. So this will give me a very good guidance of the direction where I have to go with my implant. So we continue. So there it is. And then you can see the reverse bevel Langenbeck that's going to be placed in that position. And now on the other side, we have created the bony window right at the top. And again, here we have the choice of either using a diamond burr and then creating a large window. The other option is to use the same vulcanite burr and then create a sort of a window. The only difference is I'll not be preserving any bone there, but then this is much quicker. And contrary to expectations, we don't perforate the membrane with this as much as we used to think we would. So it's much quicker. You create that uppermost part of the window and then come down to wherever I think is the second premolar or first molar. A lot of irrigation. So this is stripping off the membrane. And I sometimes use this copper retractors to protect the tissue and also to prevent the buccal fat from herniating through, because that sometimes is a big nuisance. The same thing can happen sometimes when you're drilling here and you're gone into the infratemporal fossa here. The moment you go there, you will see the buccal fat herniating. So that's a big nuisance. Then you have to take this narrower elevator and go and protect this membrane. And I also I just take a lot of bone wax and seal that area so that the bone, the fat doesn't keep herniating more and more. You put the bone wax. I've got this copper retractor here, malleable retractor there to move this soft tissue away, and then I can continue to drill. If you don't do that, every time you take the drill there, the fat comes more and more and you cannot proceed. So that's an important tip for you, keeping that fat away, keeping this instrument. And this part, the posterior wall of the maxilla, is as far back as possible you should be placing your implant. And if you're doing a quad zygoma, that will be one position, and the next implant will be coming anteriorly. So that's a round burr to start off that my initial position point of contact in the entry point. That's the entry point into the zygoma, which is made with a round burr. Now, if you look carefully, this is the alveolar crest that I've trimmed. We already perforated here because of the root infection and the root of the tooth which was extracted. So I'm going to be placing the preparation like this. So that's a window. That's the entry into the zygoma. So some of this, the annotation that's happening here, because may not relate to the steps. So don't look at these words too much. I will keep explaining because sometimes there's a mismatch between these wordings and what the legend and what's happening. So anyway, the round burr is to initiate the process. So when I'm going with the zygoma drills, again, copious irrigation, this is the extra sinus technique. The important thing is to keep this drill body very close to the bone. We have to literally hug the bone or groove that bone so that the implant will be lying on that bone instead of being away from it. And you can see that the Langenbeck is there. So the moment I penetrate and go through the outer cortex, I'll hit that. So I'll know that I've gone through. I mean, you'll also get the feel as you're going through the bone and then you're gone through the outer cortex, you'll feel the instrument dipping in, but you'll also feel it hitting the Langenbeck. And it's also a protective instrument. For me, if you can, once you get the Langenbeck there and extraorally, if you know that the position is lateral to the orbit, if you aim towards the middle of this instrument, you're in a very, very safe position. So that's the next enlarging drill. So this is a depth gauge. So the depth gauge is almost the same diameter as the implant. So it will tell you the accurate measurement of what implant length you want to place. So 30, 35, 40, 45, 50. So you know where we are. So this is the markings in this depth gauge that you can use to plan the implant length. And you can see the emergence through the outer cortex. So that's important that you see that and do engage this cortex. It's very important. And you want to know the exact measurement because we don't want this implant to be going 3-4 millimeters beyond that. That's a problem because then the patients can feel it. And if the thin individual, they can even see it. So you don't want this to be going too far beyond the zygoma. And then once you're done the preparation, so this is the Nobel Zygoma, which is, I think this is a 0 degree. So this is a newer design. So we are placing this with, so that's the threaded part, and this is the smooth part, external hex design. So some of the implants have a 45-degree head. This one has a 0 degree. This is a newer design that they've got for a variety of reasons. Now, this is a problem because this is an exposure into the sinus. So we need to create a good seal over there. We need to put some membrane. See this? This is important that we seal that. So now on the other side, the same way, you're just making a window with the vulcanite burr. Just creating a pathway. So very similar to the other side. So that's called the zygoma hook that goes through and through. So in case you can't see it, because sometimes if your exit is right on top or a little posterior, you will not be able to see this tip. Then as you insert it and get out, you can actually palpate it. With tactile sensation, you will be able to see this advancing to the outer aspect of the zygoma. So then once you've finished the drill, you again place the implant. The 0 degree implant is usually placed much deeper in the bone because the abutments are quite long. In these, there are 6 millimeter and 8 millimeter long abutments. So you need to place it fairly deep. And this is important. You see the combination of an extra, you're really deep in the sinus. So, and once you put your mucoperiosteal flap here, there's a good chance that this can form bone. If this was far outside, then there's a concept of bone envelope. So within the envelope, if you're there, there's a good chance of bone forming even on the buccal side. So then we are supplementing it with 2 implants in the anterior region. Again, some people like to place the anterior implants first and then the zygoma so that they can have an idea of the position, but that's not a, it's a personal choice. You can do either way. So these are the abutments, multi-unit angled abutments that you place. So because we want a completely screw retained processes. So multi-unit abutments are the weight an advantage. So you're getting close to 35. This is 35 and 70 newtons, 2 markings. So you're getting 35 newtons primary stability. So once you get the primary stability, then you can, you know, so this is the PRF, the platelet-rich fibrin. So remember I was telling you this was the only area of concern for me because there's communication to the sinus. Then we need to place, you know, soft tissue, make this membrane, and then make sure you get good keratinized, this mucosa is covering up to there. One other thing you can notice, so we had a crestal incision, but because these implants are emerging towards the palatal side, towards the cingulum, I could punch this. So these implants are emerging in very good keratinized tissue. And then my incision line actually becomes almost like a Lefort 1 incision, the closure. So this punch line will take the implant emergence in very good keratinized tissue palatally. So, and then 3-0 Vicryl for suturing. And then almost at the same time, we start with the prosthetic impression technique. Okay, so we go on to the, continue with our presentation with the complications. The complications that are described are largely sinusitis. Then comes soft tissue infection around the implant, emergence region, and then paresthesia with infraorbital nerve distribution, and also for the zygomaticofacial and zygomaticotemporal nerves that emerge at the body of the zygoma. So some people have complained of, you know, the hyposthesia in relation to the zygoma, but not a major issue. Oroantral fistula is certainly the most the complication there to worry about, and make sure you can either prevent it, or if you identify it, correct it immediately. So depending on studies, the sinusitis risk has ranged from 0 to 37. 37 is very high, actually. It's usually around 2 to 3% in most of the studies, but there are some reports with very high rates of sinusitis. And it is related to these pre-existing pathology and perforation of the sinus membrane, which is either not recognized or not treated, loss of bone around the implant crestal region, and definitely poor oral hygiene. One other thing they have shown recently is if you have large inferior turbinates, that is also as a contributory factor for sinusitis. So the different design has been addressed, the Nobel implant, because of the smoother design, and there are certain other implants also which have the thread only at the apical and smooth component remaining. So all these are advantages for the new designs are advantage. So here, if you get these threads exposed and it's still locked in, I would like to put in some sort of graft. We have done this, but I find it not very useful. It's much better actually to use soft tissue, either put some PRF or put some buccal fat or membrane. Those sort of things are much connective tissue graft. All these are much better than putting any bone in this region, and then close it up. Other complications like circumorbital ecchymosis, injury to infraorbital nerve, and then loss of implants. Loss of implant is certainly the biggest problem. So these are, of course, self-limiting, but you should warn the patient. We are talking about soft tissue infections. This was a patient who developed infection near the exit point of the zygoma, and landed up with an extraoral sinus. So we were quite puzzled because there was nothing untoward for this patient in good health and everything. So this happened almost a year after insertion. So we took it for culture sensitivity and then asked him to do culture sensitivity, and also asked him to recheck his plasma glucose. And we found HbA1c to be 9.4. So he had become a recently diagnosed, he was absolutely normal during the surgery. At that time, when we had done the pre-op workup, he was normal. So he had become diabetic in due course in this last 3 months or 6 months. So, and then with the, with antibiotics and control of diabetes, completely resolved. The whole extraoral sinus healed, and he's comfortable now. We didn't have to do anything further. His sugar, we just re-emphasized that he has to keep his blood serum glucose under control. What do you do in a failed implant? Literature, Bedrosian's articles and all say we re-enter after 3 months. We had one occasion like this gentleman who had a quad zygoma. We didn't load one implant because of poor initial stability. This was immediate after. Then within about 6 months, we did load him fully. So all the 4 implants were functional. But 1 year later, he started losing bone on the left side, and we lost those 2 implants. So infection, persistent infection and mobility, we had to remove this. The right side was normal. So we just continued with a removable denture and waited for another 3 to 4 months. We did a scan. The radiologist was not happy with the bone fill. He waited for another 3 months. And then once we knew that the zygomatic bone had healed well, we went in and put 2 more implants in exactly the same place, because there's no other bone to place implant. It's in exactly the same place that you have to place the implants, because that healed nicely. We got good stability in the same position, and then we could restore him with another full arch prosthesis. So this was the only patient where we had re-entered and we had a good result. Now, one problem that we had was in this head of the implant getting deformed if you use too much torque. Ideally, we should stop with 35 to 50 Newton torque. All of these kits sometimes come with a hand torque wrench where we can apply quite a lot of force on these implants. The problem is nothing happened to the implant, but the moment you apply more force, the head of the implant deforms. So in this patient, we caught it a bit early. As it started deforming, we stopped and we could get the multi-unit abutment, although not in ideal position, and we could restore. But in another patient like this implant, that external hex got completely deformed. So you're gone in with about 75, 80 Newtons. You try to undo the implant. You want to take it off. It completely, this implant head gets deformed. So we had to completely leave the implant as it is because if I wanted to try to remove that implant, I would have had to drill the bone completely away here only and then take it off because there's no instrument that will hold it and give the reverse torque. And if I do that, I lose whatever zygoma bone is there. So what we decided was leave it as a dummy, place another implant just adjacent to it, like a quad zygoma, unplanned though. So we lost one implant. I mean, this was a dummy implant, but at least I could retrieve the situation. We could put one more zygoma and then complete the procedure. Now you understand the importance of keeping one implant. Even if you're planning a single implant, try to keep it as far posteriorly as possible. If this implant had been right in the middle of the zygoma, I would not have had a place to place another implant. So it's always good if you're doing a single zygoma implant, try to keep it as far posteriorly along the posterior wall of the maxillary sinus, and try to engage the zygoma as far posteriorly as possible. So you have enough space anteriorly, one, not for this sort of situation, but more in case you need to come back with another zygoma later on. For example, your anterior implants are failing. You need to come back with one more implant. You've got sufficient bone. If you place this implant right in the middle, there's no way you can get another implant medial or anterior or posterior to it. So this was a situation of a deformed head where we couldn't use that implant. But we could save the situation. If you have overextension of the implant beyond the superior cortex, people have sometimes gone with an extraoral approach, lateral orbital approach, and gone and trimmed that extension. So we have never had to do that issue, but again, because we are careful, we have definitely gone a millimeter, sometimes beyond it, but that's not an issue. They don't feel it and it's not visible. But if you go beyond 2-3 millimeters, then it can certainly be easily palpable for the patient and sometimes even visible for a thin individual. We did discuss about this damage to extraocular muscles. This is known to happen and it's been published. Watch out for this unusual complication of this. This is available in the, if you do a web search, they'll say intracerebral penetration. And this is one of the most frightening things for a patient to see. If they've done a Google search and come to you, they're not going to come to you, I think. They see an intracerebral penetration as a complication. But the unfortunate thing is this is not a zygomatic implant. Although the title of the article became like this, it was actually a regular long implant, 18 millimeter implant that was placed in the region of the zygoma. I think they wanted to place it in the pterygoid zygoma region by an inexperienced surgeon, and was doing it for the first time under general anesthesia. He's so used to patients sitting up, in a dental chair and laying implants. He had he didn't adapt himself to this altered position of the patient lying, supine. So landed up with this a very unusual complication. So we need to be wary of this. And of course, the problem with this patient did not have any problem till about 6 months later. And the only problem the patient had was, and the patient was fully restored. The patient came back with headache, after about 6 months. And then they had to see a scan, and the FOVs there will only allow you to take intracranial. They won't see anything. They just saw the report was an unusual foreign body intracranial. Then they had to go back to the history and come back and find out this. So these are the problems you should be a little wary of and be aware of, because patient may come back and ask you about it. So we are coming to the absolutely last part, some interesting cases, and just run through a little bit. Here's a young ectodermal dysplasia patient with these sort of teeth who could be managed with the quad zygoma and lower all on 4. And mind you, most of the patients that we see here today are not older patients. We are seeing more and more indications for younger and younger patients. And that's where I think it makes it, real, very satisfactory for us as surgeons if you can rehabilitate these patients. You're not just giving them teeth, you're giving them a whole lease of life at a young age. So this is another young gentleman who had ectodermal dysplasia. When he came to us, he had already had a couple of osteotomies. And he came to us for rehab. So we had to do bone grafting in the lower jaw because it was completely the resorb mandible. Maxilla also, you can see there's virtually no bone. So we had to do, after the bone graft, we did stage 2, we brought him in to do the lower all on 4 and upper quad zygoma and restored him. So this is another patient, syndromic patients, again, see the hopeless dentition, again, a young patient in the mid-20s. So again, you can do, from here to here, this is a transformation you can bring about these patients. Then we have had some interesting cases of what's called primary failure of eruption. This was, early 30s who had teeth, unerupted teeth, and these deciduous teeth has started to become mobile. And she was an IT employee, and so she obviously couldn't go with some removable option and all that. So we looked at, so this is primary failure of eruption. We ruled out other reasons. There was no other systemic reason for failure of eruption. So we decided we told her that we'll get rid of all these teeth as far as possible and then do some grafting or implants if possible. We were lucky that we could get out these teeth and in the upper and lower jaw, and we could place 2 zygoma implants and 2 tilted implants anteriorly because there was no bone anywhere else. We had to go along the lateral nasal wall with tilted implants, good stability, grafted a little bit of it, and then restored her with the immediate provisional. And whenever you can retain the second molars, try to retain them because they give you the stop. You get exactly the same vertical dimension as pre-op. It also gives you some proprioception. So if you can have, we have been able to do this for 3 or 4 patients where we could save the second molars and keep the vertical dimension and then restore the remaining. So she goes from here to here, and she's now almost 3 years. So this is another situation. These were twins who had, again, similar situation, primary failure of eruption. So we had to get rid of those teeth and simultaneous implant placement. Some of the implants, we don't get enough stability, so we don't load the primary stability. I mean, the interim process is only on the implant that we get more than 35 Newton stability, and we have stabilized it. And this is, the patient who gave us so much satisfaction from the treatment point of view because she was the youngest patient reported so far. At 17 years and 10 months, she was a very bright kid, right from younger days, wearing complete denture. And she was getting into a medical college in Andhra Pradesh. The parents said that she is going to give up that seat because moving from a village school to a bigger city and to go with a removable denture, she said she's just not going to be able to handle it. So because her growth was complete, we said we don't have to look at the chronological age, we have to look at skeletal maturity. And we know that maxillary skeletal maturity is certainly not, happens 2-3 years post menarche. So we took that stand and we did zygoma implant for her. So this was, one of the patients who we had, we really felt happy that we could do something really worthwhile for this papillon-leaf syndrome patient. So, ladies and gentlemen, in conclusion, I would say that zygoma implants are a very predictable and highly successful treatment modality today for dental-alveolar rehabilitation, but certainly requires teamwork and good training. So thank you very much for your kind attention. It's been a long presentation, but I think we have come to the end of it. Thank you very much.
But we still have some questions to go, sir.
Oh, okay. All right.
No
Okay.
escape so soon.
Go ahead. Yes.
Yeah, Nitin, can you start? Nitin, are you there?
Yes, sir. Yes, sir. So, sir, any tip to end the hex of a zygoma implant in the perfect position? Means if there is any clinical tip in getting the perfect position.
See the hex position. Okay. The usually when we check with the depth gauge, there are some instruments like the depth gauge is actually angled at 45 degree. So when you place the depth gauge in the prepared site, you will have a rough idea of what the angulation is. When you're placing the implant, you have the position of the abutment screw, and you also have the position of the implant mount screw. So that will give you an idea. The 45-degree implant, you have to make sure that it is tangential to the occlusal plane. That will give you an idea where you should stop the hex at. Of course, if you have gone a little extra, it doesn't matter because you've got 6 positions of the hex, and the abutment has another 6 combinations. So actually, you have an option of having 12 positions. That's an advantage of this. They call it the dodecagonal position. So 6 plus 6, you have got 12 positions. So although you aim to keep your hex, tangential to the buccal plane, if you're a little off that, you can still manage with your angled abutments.
Okay, sir.
And sir, if unilateral defect is there and there is a lot of resorption in one quadrant, but the other quadrant is having natural teeth or the bone is preserved,
yes,
then how would you manage? Like do you change some position of your implant, or you shift to a total smooth surface implant, which can be out of the, soft tissue?
I have to think, because I have not had that specific occasion, where we'll have to have a two, basically what it
Alveolar
looks is
height.
alveolar levels, right?
Yeah,
Two different levels of the alveolars.
Yeah.
I would probably go with some bone reduction because on the alveolar side, because once you're saying that you're not going to have extraction of that side, right?
Yeah.
You're going to preserve one side, and it becomes like a partial situation.
Yeah.
Then there's no question at all.
Sir.
I think I don't want to bring the implant outside the soft tissue. I want to keep the implant in. I'd rather use longer abutments or custom abutments. I don't want the implant coming out like in a maxillectomy situation. I'd rather keep the implant inside bone or under soft tissue, under periosteum. I'd rather have custom abutments, which are longer abutments, and then have the teeth in the same line. And which makes it also easier for a hygiene point of view. You'll have long abutments which can easily maintain.
Okay, sir. Dr. Mukul?
Yeah, a couple of questions. One is, any protocol in patients who are on bisphosphonates for your implant patients, and patients who are having osteoidal necrosis when the implant exposed? Anything different you do?
I have not had an occasion with a patient, but I've had patients who have come and how we have planned. If they are on bisphosphonates, if they are on IV bisphosphonates, I wouldn't do implants.
Okay.
It's like just like any other regular implant. If for me the protocol is IV bisphosphonates, I wouldn't do implants. If they are on oral bisphosphonates, I will look at the dosage. I will see what type of oral bisphosphonates. Okay. We've got so many newer preparations today. Instead of the classical bisphosphonates, you have monoclonal antibodies, the Rankle antibodies. You have a teriparatide, which is like a parathyroid hormone derivative. So which are much better and very less chances of bone-induced necrosis, osteonecrosis. So if they're on any of the newer medications, I'm not worried too much. But if they're on older medications like classical bisphosphonates orally, then I would certainly look at their bone densities. I would I mean, there is, I mean, you can measure CTX levels. They look at the 150 micrograms or nanograms of the CTX, the C peptide, the serum C peptide levels. Huge controversial issue because Robert Marks and all says if you get more than 150 levels, you're safe. You can do implants. But there are equally strong arguments against it, saying it is not a predictable predictor of safety as far as osteonecrosis is concerned. So I don't, and we tried actually, it's not possible to do it in Chennai. I don't think it's available in India also. So we can't even do an serum CTX levels. So I just go by the clinical presentations and if what medications they are on and what sort of what is their bone density at that point of time with the bone scan, whether the osteopenic or osteoporotic, if it's what standard deviation, if it's more than minus 2.5 and osteoporotic. And if I can have a drug-free interval. Okay, if we can have a drug-free interval of 3 to 6 months and then do one more levels, and if you're happy with it, then you can do implants. And I would not load them immediately. I would delay load these implants. So that's the protocol I would take for people on bisphosphonates. And again, like any other situation, don't look at just bisphosphonates. Please look at other cofactors also. If they are bisphosphonates and they're diabetic, not under good control, if they're smokers on top of it, and if they're on steroids, and if they are drugsers, be extra careful. So oral bisphosphonates, not an absolute contraindication, but you have to be very careful. One more thing that you have to be very careful as far as medication is concerned, you know, be aware in Boston, they showed very clearly that people on antidepressants, anti-anxiety, the serotonin reuptake inhibitors, SSRIs they call them, selective serotonin reuptake inhibitors, almost all the common brands of antidepressant and all will be belonging to that group of antidepressants. Patients who are taking that have a higher chance of osteoporosis and a higher chance of implant failure. So please look at the medication history of these patients because we see a lot of these patients who are on medications, and if they are on selective serotonin reuptake inhibitors, be very careful on doing implants on these patients.
Nitin, take the
Yes, sir.
next question.
Yeah, sir, next question is indication of 45-degree head and difference of that 0-degree head and 45 or angulated head from Zygoma implant from Nobel. Like where you use which one?
Okay, see, I'm actually comfortable with the 45-degree because I'm comfortable placing that implant and I'm very comfortable knowing to position the hex correctly. But if somebody is not very comfortable with that, then a 0-degree is better because with the 0-degree, you can you have multiple more positions of you need not place it in an exactly buccal position. The position of the hex is not critical. So from that point of view, a 0-degree is a easier design to work with. But my concern is the 0-degree implant is usually the larger diameter implant here in India. Not in India. The Nobel one is actually a 5 millimeter and a 5.5 millimeter head. For me, with our zygomas, if I want to do a quad zygoma, that gives me, it puts me at a very, very tight spot because I do not have enough bone for a quad zygoma. I have to be very precise. Even if I'm 1 millimeter, or maybe 5 degrees away, my implant apices will come too close together. So for that reason, I don't like to do the 0-degree. I prefer the 45-degree. Technically, little more, you need to be a little more careful on how you position the head of the implant. But believe me, that's not so difficult. You can easily learn that, and much better to do with a 45-degree head implant.
Okay. So what is the maximum torque for a Zygoma implant? If you can.
Depends on how strong you are. Okay.
before it breaks.
Before it doesn't break, actually the head deforms.
Yeah.
That is a problem. See, the implant has become very strong. The hex deforms, and then you're finished. You can't do anything with it. Okay. So that is where I feel if you go beyond I feel beyond 55, it's 50, 55, so I'm very, very cautious. I'd rather reverse it, go back, or completely take out the implant, redo the osteotomy, and place the implant again. I don't want to go beyond 35, 40, 50 Newton torque. I just one more thing I just remembered. For a 0-degree implant, you have to position the implant far deeper in the bone compared to a 45-degree. For me, that is another problem, because once you place the implant deep in the bone, say the abutments are all very long, 6 millimeter, 8 millimeter. At any point, if your abutment gets loose, implant abutment getting loose is a common complication, prosthetic complication. If I have to approach that screw, I have to open the flap in the palatal side. So one more, a local anesthetic, opening the flap, getting the access, tightening, suturing. So it becomes much more cumbersome, the patient point of view. In a 45-degree implant, it is much closer to the mucosa. So if the abutment screw loosens, it's easy to tighten it. In a 0-degree, it becomes a minor surgical procedure. So for these two reasons, actually, this was told, my prosthodontist had huge problems one day, and then say, come and open the flap. I said, for what? For abutment, you want me to open a flap? Then they said, no, this is a problem. So once I realized that, it was, for me, a second vindication that we should not use a 0-degree. I prefer a 45-degree implant. I didn't hear anything.
No more questions.
Nitin, you need to unmute yourself.
Yes, sir.
Yeah.
Yes, sir. Sir, does a CBCT is sufficient, or we require a medical CT scan for our zygoma planning?
CBCT is more than enough. If you have enough adequate FOV, I think a 10 by 12 FOV is adequate for a zygoma implant. If you don't have that FOV, then we have to do a medical CT.
Okay. And sir, you just mentioned about serotonin inhibitor drugs. So how long the patient will be taking, like if the implant will go for a failure? Like what is the...
I think they're like most of the other medication, the longer they have used it, the more chances of failure. Yeah, certainly. But I can't recall what is the duration exactly. But certainly, like any other thing, the longer the duration, the more chances of them having a failure, with everything else being equal. So
okay. I think, sir, YouTube questions are over.
I think Mukul, any questions?
Hi. As he asked the question of this post-operative sinusitis, can you do FES? As we discussed that.
No,
people have. Oh yeah, good question.
Sinusitis.
Yeah.
Can FES solve that problem?
FES will help, like FES helps in any other sinusitis situation. We all know how much it helps, right? So it helps the surgeon more than the patient, I think. Okay. No. I see. I think antibiotics work as well. If you can get also a culture and do a sensitivity test and do antibiotics, even better. Any of your nasal decongestion measures help. FES probably will also help. But the problem is most of the sinusitis cases are from an unidentified small oroantral fistula. Especially if it's distal or posterior to the emergence of zygoma, you won't even see it. The patient may not even feel it. But the presence of an oroantral fistula is considered to be the most critical, most important reason for getting sinusitis. Not even this exposed threads and exposed threads and all that. So we have to be very, very careful about preventing an oroantral fistula. And if there is some suspicion, identifying it, so be very, very watchful about checking out for a oroantral fistula.
Okay. And what is the biggest complication you have had in your series of cases till now? Can you...
My biggest problem has been this failure. When you had a failure, you think that's the ultimate, rehabilitation option. If it fails, you have to explain to the patient, because you have told them everything. This is the best, and there's nothing beyond this. So what happens if it fails? So, okay. Although interestingly, there are some reports which says if that fails, go ahead and do a sinus lift, grafting, and come back. I don't think that works. I mean, how can you convince a patient to go for another 1 year's treatment if the zygoma has failed? But Bedrosian has described it, and I've shown you one case where it's worked very well. When you have taken it off and gone back after 6 to 8 months later, it's worked very well, provided you are very careful with loading protocols. That's very important. The loading protocols, maintenance, hygiene maintenance, recall. See, these are problems in a patient. You have to call them for a recall very often, every 3 months if they've had a problem. And then hygiene measures, give them, although people, a lot of them don't agree to using a water pick for these patients because they feel a water pick produces too much pressure at the soft tissue level, and it can actually be a detrimental thing. So what we tell them is to use a water pick from the palatal side, because where the tissues are much more thicker and more keratinized. So oral hygiene maintenance is very critical. Not smoking is going to be very critical. These are very important things to prevent a failure.
And retrieving a Zygoma implant is not very easy, right? When it is not restorable or anything of that sort, you want to go in and remove it.
You will curse yourself, curse everybody in the theater when trying to do that. I had to remove one implant because that was too right in the middle, and I had to remove it to be able to place another implant. I tried cutting it, the amount of metal that was flying, I said, forget it, stopped it. Then what I used was a thin, long shank Fisher burr, just cut all around, around the implant at its insertion into the zygoma. Okay, it's like, how they say, the best implant is osseointegrated implant is the one that's in the wrong position. Here you're tightened it, you're gone up to 80, 90, and it's fractured. You take that drill and you go, but we could retrieve it, basically using a very thin, but that was a time I was a little worried, because you don't have any instrument to remove it. We had to use some bone rongers and little thicker bone rongers and try to, reverse it. That's the time I really prayed that the zygoma shouldn't fracture.
Yeah, so that's my question.
That's worry. So that's why you drill more and more till you get little lateral movement, and then you can take it off. You have to have a lot of patience. You may take even half an hour, but it's worth it. Do it, take it off. Then you can let it heal. It will heal very well, and then come back and redo the procedure. No over-torquing. Be careful of over-torquing.
Okay, I think I have completed my questions on Zoom as well as a fantastic lecture.
Anjan, you have anything else?
No, I think that's what Veerabha was also going to ask. I think is, have you ever fractured a zygoma while placing?
Fractured a zygoma. Anybody else? Any reports?
That was the final question that I had.
I have a question.
Who's?
Pramod.
Yesterday,
liquor shops are open. No, it's his internet. For me, you're not clear. Internet is poor. You need to move away.
Oh, he has a
type. He's slurring already.
No, it's an internet issue. Pramod, come back. Pramod, come back with your question.
I think I thought I heard Sankalp saying yesterday that he would use the threaded zygomatic implants over the new so think it has any relevance?
No, almost the older existing companies and even the newer ones are all moving towards this combination design. When you said the thread at the apex and smooth surface at the remaining part, that is certainly the way everybody's gone. And I see there's a very valid reason for it, because if you get an exposure, you saw some of my slides where when you have the thread, it's almost impossible to clean it with this, the muck correcting around it, the plaque and the calculus. When it's a smooth surface, it's so much easier to polish it and keep it clean. So the thread design, all the continuous thread design, unless you're doing an intrasinus technique, the Brennemark technique, it doesn't make any difference. But when you come into the extrasinus technique, it is certainly better to use this newer designs.
The reason I asked this question, sir, is because yesterday he made a comment, and I'm confused because I think Sankalp has come back into the Zoom now from YouTube. Sankalp, if you can hear me, my question was that you mentioned you would still prefer a threaded implant over a smooth implant. Sankalp? Can you hear me?
Sankalp, you can speak now. You're unmute. Sankalp, I think Pramod, he is still answering some questions in YouTube. I just saw him answering. He's come here, but probably he's still in the YouTube.
Sir, I have a question. Where is Guna, sir?
Yeah, go ahead. Yeah.
Sir, which technique you follow? Like I think Stella's extra sinus technique or Cho's, like with the more a bigger window?
I prefer James Chow's technique.
The bigger window.
Bigger window.
And do you graft?
I don't graft. No, not at all. I'm a little careful with the sinus. For example, if the sinus perforation happens, I like to seal that with the PRF or with the resorbable membrane, because we know that moment you leave the whole tissue to set back and you got a periosteum on the other side, you get bone.
Yeah.
The grafting has been shown to not help at all. I've tried grafting; it doesn't make any difference. It just disappears.
Thank you.
I think Sankalp is here. Can you hear us, Sankalp, on Zoom? He's trying to say something, I think, but it's okay.
Sankalp, can you hear us? Yeah, he said he's joined Zoom because he has to run the Mentimeter now immediately. So we need to check on his.
That's why I called him back.
Sankalp?
Sankalp, you need to turn your YouTube off.
Sankalp, can you turn your YouTube off and be only on Zoom?
We can see you.
No, but his internet is not good. Probably let 11 will be a standby for the Mentimeter, please.
Pritam, can I make a comment? Hello, can you hear me, sir?
Yeah, we can
Yes,
hear
yes.
you. Yeah.
I only seen Dr. Gunasheelan asking so many questions to all the postgraduates during the exam. So happy to see so many. It's a great, excellent, sir. Very, very fabulous, very elaborative, illustrative lecture, sir. Really
Thank
great.
you, man.
Thank you very much.
Thank you. It's an honor to do it when you are the president. I don't see a presidential collar though.
You should ask Preetham, sir. He has to send it a courier.
So we did it virtually. We collared him, sir.
Yeah.
Okay, I think.
Guna, any final last minute points? Anything for the younger, surgeons who might want to be starting on zygomatic implants?
I think the Zygoma implants are just going to grow for sure. And you can make a huge difference in people's lives when you do Zygoma implants. So please make it a big part of your dentalvalvular practice.
I think we've got Dr. George Paul here as well. So both of you, what's your take on, non-maxillofacial surgeons placing zygomatic implants?
George Paul sir has to unmute himself. Can you tell him to unmute? So you have to unmute.
Georgie, can you hear us?
Yes, sir, but he has to unmute.
I can't speak.
Yeah. Now we heard you. Go ahead.
Guna, that was great. Guna. I haven't seen Zygoma being placed. I'm kind of young, so I think I will pick it up soon. Make a big difference, perhaps. Yeah, but so it was very nice. It was very nice.
Full-time questions in between. Each session you need one question. I missed out. Zygomatic implants, Anna.
Problem of Zoom.
Now you can start, sir. He's been muted.
Okay.
Robin has been muted. You can speak, sir. George Paul, sir.
No, I was just saying that I'm growing younger and I probably should start doing Zygoma implants, perhaps. But I hope I was young. I mean, it looks like a very exciting area to go into.
But Georgie, we were saying that as zygomatic implants, is it something which only is it a purview of a maxillofacial surgeon, or is there, if you're trained?
Absolutely. Try getting a cardiothoracic surgeon to do it. I'm sure. No, I think it's absolutely. I mean, it's very, very maxillofacial. Very maxillofacial.
Okay.
So why would you ask a question?
Anjan,
I think
Anjan, if there's no more
I
question, let's go to the Mentimeter, please.
we should run the
Yeah, Mentimeter. We'll start running.
before people go.
Start running the Mentimeter and then come back to meet all the co-host and the speaker.
Thank
Okay,
you very
Ravi?
much, sir. I take leave.
No, sir, we are running the Mentimeter app and meeting again. Please
Okay.
stay back.
Yeah, should I mute and go to?
Yes, sir. Mute and yes, sir. Just mute. Please, all the co-hosts, please mute. Dr. Ravi will run the Mentimeter app for the pre-lecture 2 questions, which was remaining first.
Okay.
Right, and then Sankalp will take over for the post.
I think
Preetham,
Yes, yes,
that
Pramod.
is not going.
Yeah, if in case Sankalp's internet is not good, Ravi will continue.
Yeah, I'll continue. That's what I've been told. I'll continue.
Yeah. Sure.
Pre-Mentimeter is not going to run.
Okay. Okay, then we'll do only the post. 11
No, I'll just mention the questions of the pre.
Ravi, we are going to do the
questions
post
were there.
Mentimeter.
Yeah, and
That's
post
okay.
also.
We'll just do the post.
Yeah, you will read out. Yeah, correct.
11 please, can you please open the code for the post Mentimeter app? So all the participants, kindly open your Mentimeter app or visit www.menti.com and we'll display the code. So you can enter the code for the post lecture Mentimeter, please. Oh, you can open www.menti.com. 11 please share the code. Once you open the menti.com, it will ask for a code. We'll share the code in a couple of minutes. Yeah. So all the participants, kindly open your Menti app or visit www.menti.com and use the code 245623. So please open your Menti app or visit www.menti.com and use the code 275623. So till the time you guys open the Mentimeter app or visit the www.menti.com and use the code 275623, Dr. Ravi will explain the 2 questions we missed on the pre. Ravi, can you use this time to just explain? Let the screen be the same thing.
Yeah, okay. So the next, we finished 4 questions and because of some technical issues, we couldn't go further. So now I'll just discuss those 2 questions, the remaining 2 questions, but you won't be able to press code for that. So the next question was the maximum thickness of zygomatic bone is in the range of, so there are 4 options now. The first one is 9 to 12 mm. Second is 20 to 25 mm. Third is 4 to 11 mm. And fourth is 30 to 50 mm. As it was discussed by Dr. Gunasheelan sir, the Indian population, mainly Indian population, he said is around 7.5. So the range which falls in this is 9 to 12 millimeter is the right answer. And the next question, the last question was, a zygomatic implant can be used on its own to support a single tooth crown. So the answer, the options are true or false. Basically, it's not meant for a single tooth. The zygomatic implant is not used for a single tooth replacement. So the answer is false. So we'll start with the post now.
So
Yes, we can start with the, yes, please start with the post.
Okay, the first question is the Brennemark zygomatic implant has a crest module, which the first option is lies at 30 degrees to the long axis of the implant. Second is an external hex connection. Third lies at 45 degrees to the long axis of the implant. And fourth is option 2 and option 3. So you have a long time for the first question. So I think all the answers were there in the presentation. I think Sankalp's internet has started working. Sankalp, if you want to just take over now.
No, please continue, sir. Continue. It is same.
No, you'll be more versed with all these questions.
No, no problem. So you continue, please.
Okay. Okay, so last 15 seconds now. Okay, so the right option was both B and C. The last option was the right answer. Okay, the next one is this anyway has been discussed properly by Dr. Gunasheelan. There are always two different diameters of the platform in the whole implant. The apical part is the narrower than the crestal part. So crestal part, the implant diameter is 4.4, whereas the apical part, there is 3.9 mm. And for the obvious reasons, which were explained well by Dr. Gunasheelan. And you have a 45-degree angulation at the crest module. And the newer ones have almost 0-degree module, crest module. And again, for the same reasons which were discussed. Next, please. Okay, the next is, as per the Bedrosian classification, lack of bone in zone 1, 2, and 3 would require placement of a shorter anterior implant and a zygomatic implant on each side, bone grafting and not placing any implant, a quad zygoma implant means 2 zygomatic implants on either side, and then conventional all-on-4 and no zygomatic implants. Again, the answer was given by in the presentation. When there is no bone in zone 1, 2, and 3. Means you cannot place any implant in the anterior region. Exactly. So 36 people have got the right answer. A quad zygoma. Now you see in this diagram, the zone 1 is from the canine, mid canine to mid canine on the opposite side. That's called the zone 1. And zone 2 is from mid canine to mesial of your first molar. And same on the other side is zone 2. And beyond that is your zone 3. Now, if you're placing a single zygoma on one side, you need to have an anterior axial implant. In case you can't do that because of lack, as it was there in this option, so you need to place a double zygoma, means quad zygoma, 2 on each side. Next slide, please. Okay, in the Zaga classification, if the patient has a flat anterior maxillary wall, so that the whole implant has an intrasinus path, this will be classified as Zaga 0, 1, 2, sorry, 1, 3, or 4. So you cannot see, there is no extrasinal course of your zygomatic implant. The whole implant is from the crest to the zygoma is inside the sinus or the bone. So this will be classified as 0, 1, 3, 4. Yes, 21 of you have got the right answer. It's Zaga 0. If you see in this diagram, next slide, please. This is Zaga 0. So the course of your implant is through the alveolar crest, touching the anterior wall of the sinus, and then entering the zygomatic bone. So that's what is called as a Zaga 0. Next slide, please. If the zygomatic fixture is directed too medial towards the infraorbital rim, option 1 may entrap extraocular muscles. Option 2 is cause maxillary artery bleeding. Option 3 is leads to sinusitis, or all of the above. Remember, directed too medial towards infraorbital rim. Okay. So when it's medially, it will injure the lateral orbital wall, may entrap the extraocular muscles is the right answer. Next slide, please. So this is how, this is the slide from the Dr. Guna's presentation. So the yellow one is the answer. This was the question. So if it is too medial, it will entrap the ocular muscles. And if it is too medial, then only it will go in the infratemporal space and may injure the maxillary artery, which was one of the options, but wrong option. So the ideal angulation would be the red line. Next slide, please. Zygomatic implants can be used for option 1 is full mouth rehabilitation in the maxilla. Second is maxillectomy defects. The third is in patients with cleft palate. And last is all of the above, all three options. So just recall all the indications what in the presentation. Great. All of you have got the right answer. Next slide. This explains all the three options. So you have a atrophic, severely atrophic maxilla, you have a cleft, you have a maxillectomy case. So it's indicated in all of these. Next slide, please. The last question is, the Z guide used to measure the length and angulation of the zygomatic implants. Sorry, I'm fast. The Z guide used to measure the length and angulation of the zygomatic implants to be placed has markings from 30 to 50, 18 to 40, 10 to 18, 8 to 18. I think this was again, there was a picture in the presentation and he explained all the markings, how to measure it. So 30 to 50, 18 to 40, 10 to 18, and 8 to 18. And that's how we will select the length of your implant to be placed. Okay. Great, 30 to 50. Most of you have got the right answer. So next slide, please. So I think you must have seen this guide in the during the presentation. So there are markings on this, not very visible in this picture. There are markings on this which correspond to markings on this one. So 30 will be somewhere here, for 35, 40, 45, and then 50. So these markings, laser markings are there, which will correspond. When you insert your probe into your osteotomy, this will engage the zygomatic bone. And then you can measure the crest, the alveolar crest, and then decide the length of the zygomatic implant. Next slide, please. I think we've finished with the Mentimeter.
That was the answer.
Yeah. Thank you.
Thank you. Thank you, Ravi. Thank you, 11L. Thank you, Chinmay, for this, running this Mentimeter app. President, are you here? Dr. Veerababu? Okay, he's not there. Gunasir is, okay. Dr. Veerababu, you want to make the last comment before we run the music to end the session? Pramod? Gunasir is there?
Yeah, I think he's there, but his
okay.
microphone is off.
Pramod's Wi-Fi is poor. Can't understand what he's talking.
Is it Wi-Fi or is it the liquor shop's opening, Pramod?
Okay. Okay, President sir, you can do the last comment, and Praveen, you are there to put the music, and then we all meet up in the next. Log in with the new meeting ID, please.
Yes.
Speaker and co-host, everybody, please log in with the new meeting ID, which has been shared on the group for
Okay.
debriefing. Okay.
Thank
President,
you so much.
Veerababu sir, are you there?
He was there actually. He was waving his hand in some different login.
Yes, he came in. I saw him come. Sir,
Yes.
unmute yourself. Unmute yourself. Oh, he wants you to unmute, Praveen.
Yes. I have done. You can do now. Yeah.
Guna sir, thank you for this fantastic presentation, and co-host, everybody did a wonderful job. Yes, President sir, over to you.
Sir, can you hear me?
Yep, we can
Yes,
hear
sir.
Thank you very much, sir,
Sure, man.
for your wonderful, elaborative, evidence-based lecture. Thank you really so much. And
Thank you.
I personally picked up 3 or 4 technical tips. So thank you very much for teaching me for last 25 to 30 years. I hope still keep learning from you. Thank you. Thank you.
I want to be back to retirement tomorrow.
Thank you, sir.
Thank you, sir. So we end this session
Over
with
to-
the AMSI web
Thank
series
you.
theme music, and we all join with the new meeting ID. Back.
Okay. Yeah.